5, 4, 3, 1.
Professor Ramesh Sen, you are requested to give your inaugural address, please.
Good afternoon, all the participants, and definitely we have a very active orthopedic rheumatology group and under IOA, and I'm very happy that we have dealt with very many important topics in the past, and today we are with the topic of osteoporosis. We all appreciate that osteoporosis is something which is much more than a simple disease, whether we call it a disease because it is something a lot preventable also. And we also know that osteoporosis ends up in fractures in many of our population who is elderly. Knowing that more than 10% of our population is now above 65, meaning by very prone to get these osteoporosis and fractures. We understand that the spine is the most common area, but when we look at the implications, it is the hip fractures, which are more common injuries affecting the patient's economy, patient's ability, and eventual morbidity and mortality also. So it becomes very important to understand it, to take all the preventive efforts as well as management. We all understand that the test, there are many implications. Clinical evaluation is a different way. Then we have got various tests with their different implications also. So to have a knowledge of all of them, and then to have a defined policy of a medical management, in addition to whatever the surgery is done for the osteoporotic fractures, all these things are very important, and these needs a lot of deliberations also. And I'm very happy that Professor Jha has been very kind enough to take up all these very important topics for all of us. I really must have to congratulate him and thank him for the involvement which he's showing. And thanks to Dr. Pannag Bhushan also to have been a convener from IOA side. And I wish that all the participants are likely to have a lot of knowledge gained out of this symposium. Thank you. Thank you, Professor Jha, and thank you all the participants. Thank you.
Sir, your mic is muted.
Shall I?
It has gone to the top. So thank you, Professor Sen. And now I request our something goes wrong.
Hello.
Right. I'm not able to go back. Yes. So now I request Dr. Atul Srivastava, our President-elect, for his welcome address.
With the permission of the Chair President, Dr. Ramesh Sen, sir, good afternoon and welcome all. I mean, the IOA along with the IORA has tried to today bring to the panel the most elite class in the management for osteoporosis. And I am wholeheartedly grateful and thankful to each and every member of this panel for sparing their valuable time for this initiative. And I hope they preserve their energy, in fact, enhance it till the culmination of our venture. We are waiting to hear, listen to you all. Welcome all delegates, welcome the panelists, welcome faculty, and last but not the least, thank you so much, Dr. S.S. Jha, for the coordination. Thank you.
Thank you very much. And now, again, our Vice President IOA, Dr. Ram Chaddha, is traveling, so he is in a flight. So I will request Dr. Ashok Syam to play his audio. Dr. Ashok.
Good day, dear friends. On behalf of the Indian Orthopaedic Association, I welcome you all for this masterclass on medical management of osteoporosis. In fact, most of the elderly with fragility fractures reach us orthopedic surgeons as the primary contact and are treatment naive as far as osteoporosis is concerned. we are morally bound to help our aging population, and we are soon going to be a part of it, to add quality. What I mean is that they should add years to life and life to the few years or many years that they have remaining. It's our ambition and our passion that we can help this aging process become not just an ordeal, but a celebration. Let's hope what we learn today we can practice, and practice with each fragility fracture or impending fragility fracture that we may see today onwards. Happy learning and happy discussions. All the best.
Thank you. Thank you very much. And now I will again share the screen. So in the meantime, now is the time for his address by Secretary General, Dr. Navin.
Thank you, sir. Thank you, sir. We are
Right.
really amazed by the enthusiasm and the energy of Dr. Jha, sir. It's a fantastic program. This is the fourth master webinar on osteoporosis. And let me inform you that we have just finished the surgical management of osteoporosis and the case-based discussion here at Ahmedabad Orthopaedic Association.
Good.
And Dr. Vijay Kakatkar was our guest faculty from Nasik. And now we are going to learn about the medical management of the osteoporosis. And we are very much thankful to all the faculty for giving their 100% here to give your knowledge or tips and tricks about the treatment of the recent treatment of the osteoporosis. And we are thankful to the IT committee, Dr. Samsul Huda, Dr. Jawar Jetwa, and Dr. Ashok Shyam for coordinating completely. And now you will be able to visualize this webinar on our website of Indian Orthopaedic Association, on that web page itself. So now all ongoing will come on our website throughout the year. Now you can click and see every webinar which is coordinated with the IOA. Thank you very much, and I welcome all the delegates on behalf of the Indian Orthopaedic Association. Thank you very much, sir.
Thank you, Dr. Thakkar. And now is the time for the opening remarks by Professor Shantanu Lahkar, who must be congratulated for assuming the office of President, Indian Orthopaedic Rheumatology Association.
Yes, sir.
Professor Lahkar, please.
Good afternoon, sir. Can you hear me, sir?
Yes, yes, very much audible.
Good
Please.
afternoon. I am disabled by the host committee for my video. Anyway, please ask to open up my video, sir. The host has disabled me. Anyway, good afternoon.
Dr. Ashok, can you make his video on?
Okay, so I stop share and then he can do it. Yes, please.
Sir,
Yes. All right.
Yes, your video is
so
on now.
good afternoon, and my respected Jha sir and all the faculties and faculties from IOA. It's a great occasion for all of us that we are discussing today on osteoporosis, which is a very, very important subject, not only for orthopedics, rheumatology by orthopedic, but for all the specialty, it is becoming a very important subject. And now IORA is taking initiative to bring this osteoporosis into limelight. And I believe that today's discussion will help everybody in updating themselves, because every day there is updating. And when Jha is there, I believe that there will be more updating and fruitful discussion. Thank you, sir. Thank you.
Thank you. Thank you very much, Dr. Lahkar. So, friends, talking of osteoporosis, as has been spoken by learned speakers, we are happy that this afternoon we are having observers, which is a unique thing to have. Subir Mukherjee from Raipur, Swarnendu Samanta from Kolkata, Ravi Sauta from Gurugram, Dr. S.S. Samarnath from Bengaluru, Sarika Srivastava, an anesthetist interested in BMD and DEXA scan from Agra, Abhay Elhans from AIMS Jodhpur, Gururaj from Delhi, and Alok Agrawal from AIMS Raipur. We will have good contribution from their inputs on the various topics. So our discussion is classified into two groups, the primary osteoporosis and the secondary osteoporosis. Friends, talking about osteoporosis, as has just been outlined by our previous presidential speakers, it is a nightmare. By 2050, the projected number of osteoporotic hip fractures in Asia is going to be 3,250 and 6.260 million in the whole world. Now, morbidity associated with the fracture is very important to know, and that shows our concern. 20% death takes place within 1 year. 30% get permanent disability. Rest of the 40% are unable to walk independently. They require some aid, and 80% of the rest are unable to carry out at least one independent activity of daily living. Friends, a retrospective study suggests that vertebral fractures are the fractures which are underdiagnosed. So, out of 132 patients, only 25 have received treatment. Well, talking about osteoporosis in India, which is relevant to us, we normally understand that female population has more osteoporosis, but there is a high incidence among men. Now, the figure says, though it must be an old figure, 1 out of 8 males and 1 out of 3 females are having osteoporosis, out of which hip fractures alone are equal in India in men and women. Lower age of peak incidence is comparable to the Western world figures, but the peak incidence about 50 to 60 years of age is 10 to 20 years younger than the Western world. Now, this is such a common fracture. Talking about the WHO pattern of epidemiology, women suffer more than men, and 1/3 of women are aged 60 to 70, 2/3 of women are aged even 80 or older. 1 in 5 men over the age of 50 sustain fragility fractures. 30% of women more than 50 years, 1 or more vertebral fractures are there. Women with vertebral fractures, number 1, 5-fold increased risk of a new vertebral fracture is there, and 2-fold increased risk of hip fracture is there. 1 woman in 5, another vertebral fracture within a year is likely to take place. Well, comparing the osteoporotic fractures with other diseases like heart attack, stroke, or breast cancer, 1,500,000 patients, 750 are vertebral, 250 are other sides, 250 are forearm, and 250 are hip. And it is much larger than the other diseases. Well, talking about osteoporosis, you have to talk about peak bone mass. So this peak bone mass, which is achieved in men and women between 30 to 35, it is lesser peak bone mass in women than in men. Well, like diabetes, we say there type 1 and type 2. So here also osteoporosis, primary osteoporosis, type 1 is postmenopausal, type 2 is senile or age related, and the secondary osteoporosis we will be talking about, which is related with various diseases. Well, friends, what becomes more important when we talk about osteoporosis is the mass and the architecture. Dr. Pannag Bhushan, have you joined? Pannag perhaps has not joined, so when he joins, he will be speaking on his topic. So can I request the next speaker, Professor Manish Khanna, who speaks on challenges faced while managing osteoporosis. Professor Manish.
So, will I request to restore my share screening?
Oh, yes, sure. Please.
Thank you. Well, a very early good evening to everyone. So as the topic which is allotted to me is various challenges which has been there during managing osteoporotic fractures. So I would like to draw the attention of the So I would like to draw the attention of everybody here that we face a lot of challenges while managing osteoporosis in our day-to-day practice. Maybe a medical challenge means the drug is not responding or the patient is not responding to drug, vice versa. Secondly, when we have an osteoporotic fracture, while we manage surgically, so definitely there are a lot of challenges which we need to focus on. So my presentation will be divided into two: how to deal the medically management challenges and what to keep in mind while managing the osteoporotic fracture. While I'll always say, while performing neck surgery, osteoporotic surgery, because we do a lot of osteoporotic surgery, starting from trochanter and everything like that, even to proximal humerus, whatever it may be, that whether we are treating simultaneously the root cause of osteoporosis or not, number one. Number two, do we have designed a sufficient plan management for this fracture? So important challenges are to be addressed in this way. Why the failure of osteoporosis therapy occur? Why we are, whether we are addressing the causes properly or not. Secondly, are we are updating ourselves with the latest consensus which is available, because that's very important. What is going on should be in our mind. And lastly, but not the least, is challenges while doing the peri-surgical procedures. Now, coming to the first thing, why failure of osteoporosis therapy occur? Are we addressing the causes appropriately? Usually, this is a conventional chart. I think everybody would be appreciating it. Usually, when we start the management, then most of the time we miss few of the questions, few of the points, and that may be troubling us when the patient is not responding to the therapy. Like, for example, everybody know us that alcohol, cigarettes, and high caffeine intake has got a very important role in management, because definitely we need to take care that whether with the therapy the patient is still on the nicotine or not. What is the caffeine intake? Because caffeine, for example, a cup of a coffee having 95 milligram of caffeine, which is pretty good. And these days, these youngsters, everybody is more on coffee, so it is very important. And coffee with this nicotine is again a killer. We all know alcohol abuse is there. Similarly, we Asians have a little more tendency, so that is altogether same. And the thin framework has been indicated by the previous slide also. Thin framework persons are definitely having more chances. So we have to keep in mind, and definitely there is a link between alcohol and osteoporosis, as we all surgeons, all doctors, everybody is into it. So we should remember that if we are taking alcohol, it will going to interfere with the vitamin D absorption, vitamin D formation in the body rather, and alcohol absorption of the calcium. So that has to be kept in mind, how many days the person is having, and then whether he's on teriparatide or ibinronate or whatever it may be like, we have to take care of it. That is a very challenging situation which we miss. Again, similarly, osteoporosis is a polygenic disorder. So there are several genes which are regulating the bony metabolism, bone mineral density. According to the recent study by 2019, even 75% of our BMD is responsible with a genetic component. So that has to be kept in mind, that why this person is not responding to particular treatment. Similarly, the secondary osteoporosis, in which we know very common is steroid and immunosuppressants, rheumatoid patients, so anticonvulsant drug. Many times we miss to ask whether the patient is on any anticonvulsant or not. So there are so many youngsters who are coming with a comminuted fracture of the wrist or maybe the elbow with a not so much bigger injury, trivial injury. They are on eptoin. So these are the things which have to be remembered, which have to be taken care of, whether the osteopenia is there at that particular time, so that your medical as a surgical part will be over. Similarly, hypothyroidism is common, no doubt about that, but it is nothing to do with the osteoporosis. But hyperthyroidism will have again more rapid bone loss. So that we have to take care. I'm very much sure if we take care of all these components, then definitely the results would be, the challenges would be less in the medical therapy failure. Commonly, the failure of osteopathic therapy may be due to the compliance issue, that we can't do it just by talking and discussing with the patients and yourself. Inadequate calcium, we all know, comorbid condition we have just discussed, medication we have just discussed, and lack of efficacy of existing therapy. True to some extent that yes, efficacy may be not very good. So are we updating ourselves with the latest consensus? That is very important. There are a lot of consensus which are coming roundabout, and this is a good forum where we can update ourselves that what the latest is going on. Well, according to the various conditions, we start anti-osteoporotic therapy for the medical or the surgical region for the patient, and we further need to monitor the side effect, as for example, the pathological fractures, which may be trochanter, mandibular fracture. We all know with the bisphosphonates, nothing to discuss about that. But the most important thing to remember right now here is still the American College of Physicians is recommending these 4 drugs, in which the denosumab is the latest one. And we need to remember that bisphosphonate, in which the alendronate and zoledronic acid, which is very favorite for us, all of us, it has a strong binding capacity to the bone. That means you have to remember the what we call as the drug holiday. Just keeping on giving the drug and just waiting it, and you may be landing up with the patient's pathological fractures, or the compliance will be bad. So this has to be kept in mind. What is the duration? Should be the drug holiday? The American College of Endocrinologists still have 2020 guidelines are again the gold standard: alendronate, bisphosphonates, zoledronic acid, denosumab for the first line for the high-risk fractures. And again, for the first line high-risk fracture who are not able to use oral, are these denosumab and teriparatide. Sequential agents, anabolic agents can be added, that we have to remember. But when, I think after 5 minutes, we'll be able to sell on the other slides. First line agents for the spine is ibendronate and raloxifene. We have to remember that raloxifene is a drug for spine, not for the non-vertebral fracture. So these are the things which will help in assessing the patient. Now, very important thing, which I'm not going to go into detail, is the high fracture risk. Once you have known that this patient is of high fracture risk by the FRAC score, which is available online, then definitely you can pick up a right drug. And if the right drug is not responding, suppose bisphosphonate or teriparatide is not responding, many times it's not responding, then there are the sensitive test markers also available in the market, which are costly process, for example, PINP markers, which can be worked up, which can be done so as to find out whether the patient is responding to the treatment or not. So these are the different markers. Bone alkaline phosphatase, age-old markers, we all know for the Paget disease, so nothing to do and discuss here. But definitely PINP, that's the 4th marker, and the formation and resorption marker. First, NTX is very important. This is a slide which tells every story of everything about the osteoporosis and the complications. Alendronate, which is the most common drug which we use. Now, this alendronate is supposed to decrease the osteoclastic activity, we all know. But unfortunately, it also decreases the PINP marker. So to some extent, long-standing alendronate giving will be definitely helpful in inhibiting the osteoclastic activity. But to some extent, the osteoblastic is also decreasing. So in the long run, you have to work it out where the window period is to be given. Teriparatide, it is wonderful. It increased the PINP marker, as you can see, very well, tremendously. Altogether, it also has increased CTX marker, that is a resorption marker. But since the blastic activity is more, so we don't have a problem. That is why the more challenges which we face is the long-standing alendronate. Similarly, if you are managing a severe osteoporosis, because along with your scoring, then whether the single drug is advisable or double drug. So it is again a long story, long discussion, which can't be done at this juncture. But definitely, if you go and search the articles and publication, now it has been recommended that yes, sometime you can go for the combination therapy. Although till date, the American College of Endocrinologists have not recommended. So publications are tremendous when teriparatide can be added with the denosumab or with the alendronate, whatever it may be like. Similarly, when we are planning a surgical procedure for managing a fracture, definitely osteoporotic fracture will need a lot of attention. Dealing with osteoporotic fracture needs to remember a lot of things for the age, sex, and the quality, the combination of the bone, and what is the duration. So that we need not to tell, but definitely with the challenges which we face while replacing a partial hemiarthroplasty or osteosynthesizing anything. So implant loosening is there, intraoperative fracture, which may be heterogenic, or refractures are there, which needs attention. We should be able to remember, and still very much clear to remember in our mind, that osteoporotic therapy means bisphosphonate therapy is not going to interfere with the fracture union, because it is a drug which is given and regulate the remodeling phase, which we are not bothered about, which we are more bothered about the union. So this have to be a very important concept, which should be very well incorporated in all the PGs and all the young orthopedic surgeons who are listening here right now. And we all know that implant longevity depends upon the quality, fracture pattern reduction, implant design, and implant placement. So definitely last three are under control, but we are not under control for the bone quality and what is the fracture pattern. So we have to take care a tremendously large amount of portion on these last things. Implant loosening is a typical problem, very difficult to manage, but definitely it has been very well reported. Like in normal cases, you can have 10 to 25% implant losing without any rhyme and reason of osteoporosis. But definitely decreased holding power of plate and screw fixation is a problematic situation in which it has been done a lot of clinical trial, a lot of reports are there that bisphosphonate, alendronate, they are a wonderful drug, which in a long standing, you can work it up with a screw fixation, a long standing way. Similarly, in periprosthetic osteolysis, which we do maybe a unipolar, bipolar, which is a lot of a challenge as we are placing an implant in a remodeling bone, a dead implant in a remodeling bone. So we have to keep in mind that whether this osteolysis would be there. In that case, you have to take care of the osteoblastic activity more fast in that patient, maybe with the teriparatide according to the low BMD. And definitely the surgical care of valgoid placement and calcar is not to point to discuss here now. And still then, it's a natural process of a periprosthetic osteolysis, which we can't do it. So verdict is very much clear. As soon as we are placing doing a hemiarthroplasty, maybe cemented or whatever it may be, the first month is the period from where this osteolysis start. If the bone is very much osteoporotic, you'll need to have a speed up to a very aggressive management while preventing it, because these alendronate or bisphosphonate or zoledronic acid takes a long time to act. So we have to work it up, which type of fracture which we are dealing about it. So in the end, I would like to say that this is a slide which will show the effect mainly of vertebral component. And as we are discussing in the inauguration part also, that vertebral fractures are very important. So we have to keep in mind where we are focusing, whether we are focusing on vertebral fractures or whether we are focusing on non-vertebral fracture, and accordingly, we can pick it up the drug as wise. So peri-surgical anti-osteoporotic therapy, otherwise also medical part of it, is a paramount important and should be implemented as soon as possible and should be taken care of regularly with the patient convenience, with your convenience. It is not the end of the day when the stitches are being removed and patient's out. The patient may come back again with another fracture. It's good for the pocket, but still it's not advisable. Thank you for a very patient hearing. Thanks a lot.
Thank you, Professor Manish Khanna. I didn't introduce him because he does not need any introduction. He has been the pioneer worker in the field of Indian Orthopaedic Rheumatology Association, and he is professor of orthopedics at Ayodhya in a medical college. So now the next speaker is Dr. Sunil Marwah.
Dr. DP Bhushan has joined, sir.
Okay, so
After Dr. Marwah.
okay, so he will present after Dr. Marwah. Fine. So, Dr. Marwah,
Yes,
your
sir, I'm ready.
presentation. Yes,
Moment
please.
we stop sharing the screen, sir.
I will.
Yes, sir.
Right. Stop.
Right. Done. Good afternoon, friends and colleagues. Welcome to this session on osteoporosis. I'm Dr. Marwah from Gurgaon. I'll be dealing with the adult osteoporosis primary variety. Now, we must never forget the history and the march of science. If we forget these two things, then we are doing a lot of damage to our patients and ourselves. In that context, half a decade back in Florence, IOF meeting changed the osteoporosis management totally, which was there for last 25 to 30 years. And so I'm going to highlight a few of them. And what did they do and what did they plan? That's what is my impression. Yes, they said denosumab is the king of anti-resorptives, but with a caveat, which I'll come to later, PTH variants not to be used as yet, because we don't have their long-term yeses and nos with them. Ultra-low dose estrogen patches, I'll come to them, we don't have it. But the main crux was, have we gone wrong in last 30 years of osteoporosis management? And this was acknowledged by Dr. Kenneth, the president, that yes, we have given a wrong message to the orthopedic community, and it's high time to change it and make our orthopedic community come to the foreline in view of the last 10 years of research, what it has shown. So the message was build the bone first with PTH and then protect it with anti-resorptive. And why was it so? When we have this bone on the left-hand side, minus 2.5, and we try to protect it with anti-resorptives, what do? We are not improving the bone. We are only making it more stiffer, less tensile, so it breaks more easily. But that's not the only issue. The issue is when we are in a further soup and we come in with PTH to wake up this bone, it goes down further in next 6 months' time. So 6 months, it is still dropping further. And not only that, when it starts to wake up and come back, it does not reach the height where it would have reached properly if we had used the original molecules in the correct direction. Now, for last 25 to 30 years, this is what is the orthopedic pedigram for pharmacological treatment options. On the left side, anti-resorptive, right side, anabolic. Hormone replacement therapy came and went in mid-90s. SERMs, we handed it over to the gynecologists. They are quite useless as an anti-resorptive. Calcitonin came in 92. I used it. But by 95, 96, we had realized it is not an anti-resorptive. It only gives pain relief in vertebral spinal fractures for a few 3 months. By the time antibodies have built and it's gone. Oral bisphosphonates came in a very big manner in 96 onwards. But by 2003-04, new kid had come on the block. That was zoledronic acid, and it was slowly but certainly removing the oral bisphosphonates from the scene. Why? Because it was working 8 to 10 times better than the oral bisphosphonates for the job which we were giving them, and also with lesser side effect, but with a caveat, but with better patient compliance and everything. So this is the march of science. Then comes in 2005-06 denosumab. Now, denosumab sidelined zoledronic acid by the time it came into good use by 2010. Why? Because denosumab works at both the cortical and trabecular part of the bone, while the zoledronic acid works only on the trabecular part. So we were getting a better kick with the drug we are using. Also, the compliance was better. Also, by now, 18 years, we have not had a problem with denosumab behind this scene. The 10-year study has been released. 12 years is coming in tomorrow or day after. But behind the scene, it is an 18-year follow-up, my friends and colleagues. So on the left side, we are left only with denosumab if we are working with today's science. On the right side is teriparatide. Teriparatide came in 1998. India, it entered 2000. It is still the only anabolic that we have. Everything else is not there for us. the new abaloparatide and all, we do not know their long-term good and bad things. So not recommended by the IOF. The newer one, Denosumab, have come very expensive, but we do not know their long-term good and bad. So they are not in the pocket. Okay. Now, what changed all this whole pedigram? This was a study done by American Hospital Administration, started in 2007, 2008, and concluded after 4 years. 4 years long trial, my friends and colleagues, double-blinded trial, and it was published first time in Lancet, and then came back in the Journal of Endocrine Metabolic in 2014, and then saw the light of day in 2017 in the IOF Summit, when it was taken as the holy grail of osteoporosis till that date. And what is it? It was seen 1/3 of the patients were given double-blinded, both Forteo and Prolia. 1/3 were given only Prolia, 1/3 were given only Denosumab. And what was seen after 2 years? 2 years of concomitant teriparatide and Denosumab therapy increases BMD more therapy than either therapy medication alone. So it just reinforced our use of combination therapy when we are really in trouble. But this message had been given an FDA approval in 2004, that long back. But by this date, it further got it. And because before that, I was using zoledronic acid and teriparatide as combination till I got Prolia in hand. Now, of course, it's Prolia and teriparatide only. Now, this was on expected lines. But what happened here? When we went to data switch study, and this same group of patients, one group, the 2-year teriparatide was now put on Denosumab, the Denosumab on teriparatide, and the commission to Denosumab because it has 2 years of teriparatide. Now, this was the game changer, my friends and colleagues. We can't go back on science. We can't go back on history. We must learn and take it forward from there. So what was seen? It was seen that the patients that were on combination therapy, when continued on Denosumab, stayed the highest in all quadrants. The patients that were on teriparatide, when put on Denosumab, stayed the next highest. But mark you, my friends, look at the third line, the lowest line in all the 4 graphs, and you can see this is the line of Denosumab patients being put on teriparatide now. So when you switch from an anti-resorptive to an anabolic, which is the case for us in 99% of our patients, the bone is going to drop in next 6 months' time. And this has been proved by science before it starts to pick back. Now, when it starts to pick back after 6 months, still it does not reach the improvement that it would have reached otherwise if we had used it wisely. So, transiting from teriparatide or combination therapy to Denosumab further increase BMD, but transiting vice versa from a anti-resorptive to teriparatide, be prepared for 6 months drop and not such good bone at the end of 2 years. This is the message. This is the crux of the thing. Build the bone bank before you freeze the bone bank. This is what I want to sink in. This is what should be sink in by our current orthopedic surgeons, because if this doesn't sink in, we are nowhere. There are only 2 drugs on the horizon: Denosumab left side, teriparatide right side. So there's no confusion about battery of drugs and side effects and all. But how to use it, that's what is important. Coming to the Denosumab advantages, long-term 10 years has already been released about 3 years back. 10 years continuous BMD increase and persistent fracture reduction, no therapeutic plateau required, no drug haldol recommended, more efficacious than all bisphosphonates in improving sustaining BMD at lumbar spine, unique bone type that uptake in cortical and trabecular bone, leading to improved bone quality parameters, highest BMD outcomes till date with and after teriparatide therapy, no safety concerns, not even one stress fracture in 10 years. Only anti-resorptive drug approved for all stages of renal failure. You can give the drug without changing the dose, without doing any test. Offers long-term compliance advantage. Every 6 months, a subcutaneous injection. Patients take it very well. The only caveat is osteoporosis is a lifelong disease. And when you stop this treatment, In a year's time, the bone starts to fall again. But that would be the case because it is to be managed lifelong. So tell the patient there's a lifelong disease and you need to make it a lifelong management. If once you don't break the hip or if you're broken, you don't break it again. So what was the adequate regime for the females? At and around menopause, start microincisional dermal patches. This is not HRT. We don't have it still. But the gynecologists have shown that it differs the requirement of formal osteoporosis treatment by 5 to 10 years. We do not know the science behind it still. When the FRAC score starts showing fracture risk, not the BMD, when the FRAC starts showing fracture risk, start PTH, build the bone bank, followed by denosumab. If fracture happens while you are building the bone, come in with PTH, with denosumab right away. Turn it into a combination treatment. For males, simpler. When the FRAC scores are showing fracture risk, start PTH, build the bone bank, and then protect it with denosumab. If fracture happens, add the combination treatment, denosumab right away. So it's a very simple algorithm, my friends and colleagues, and it should sink in into us why we have to give this to our and the coming in orthopedic surgeons, both in males and females. If starting point is a fragility fracture, which is there in 90% of patients, start with the combination treatment, PTH and denosumab. Don't start fooling with one drug, because if you want to give the patient the best, what is available to science, then this is what is available. If transiting from anti-resorptive to anabolic, which is there for 99% of patients, start combination treatment, PTH and denosumab. This will help reduce that 6 months of drop, which we expect. This will only help reduce, not take away the problem. But sometimes we don't have a choice because the patients had already had all this nonsense before. So the message was very clear. Build the microarchitecture first with PTH and then protect it with denosumab. For emergency and transiting treatment, combination management is the way to go forward. So my friends and colleagues, I give a very definite, simple, straightforward message, but it has to be sunk in, because I still have about 30 seconds. I'll give another message is that 2004 to 2014, I was fighting a lonely battle about the combination treatment. Lots of meetings I would go in the country and outside the country, and for a difficult case, when I would propose combination treatment, I was sometimes told that this guy is talking nonsense. Dr. Ravi is here, he knows it, Dr. Verma knows it, we were in the same meeting, and Dr. Ram Chaddha was here from Bombay, he also knows it, that people sitting in the chair gave that message, that this is a wrong message, please remove it from your brain. And today I'm very happy that those people have been removed from the chair, not me. Similarly, in this stage of osteoporosis management, with half a decade of this current information, we should not give the unscientific information to our younger colleagues so that they are confused what to use, how to use, when to use. It is a straightforward message, and we should work with the science and not give a politically correct message. Thank you very much. I'm a little bit, I get emotionally involved. Sorry about that. Take care. Bye-bye.
Thank you. Thank you, Professor Marwah, for your emotional. Yes, Dr. Alok, you will be allowed to intervene in the question answer session. Please wait for that time. So an emotional appeal is scientifically best, but you are so firm and your message has gone home that build the bone micro architecture first. Will it be teriparatide, or it can be substituted with some other drugs? We will be talking in our question answer session. May I now request Dr. Pannag Bhushan to speak on definition of osteoporosis in relevance to fragility fractures. Dr. Pannag?
Right, sir.
Please.
Am I audible?
Audible and visible too.
Sir, as many things have been told by others, I'll just stick to the surgical part of my management. So no more slides now, because many of the things have been covered.
No,
First,
but your topic was
yes.
definition of osteoporosis
So,
in
sir,
relevance to
fragility fracture.
Please
Right,
go ahead.
sir.
Go ahead.
So the fragility fracture is the fracture when the insult or the onslaught is just from standing, fall, or less. If the patient has fallen from the standing position, or if the lesser trauma is there and a fracture has occurred, then it is known as fragility fracture. It is definitely associated with many things like BMD less than minus 0.25. Then the other factors which come up, as told by Dr. Marwah, that the architecture and the geometry of the bone. Usually, invariably, the fractures of the neck femur and the fracture of neck humerus are fragility fracture. The fracture collis distal radius is fragility fracture. The fracture of vertebrae is fragility fracture. And as the time goes by, the first fragility fracture to encounter is collisus fracture or the lower end radius fracture. After 15 to 20 years, that is around 60 to 70, the second fracture which is encountered by the clinician is the fracture of neck femur or the fracture of proximal humerus. And at the 70 plus age, there are chances that the vertebral fracture will come in. Now again, once the fragility fracture has occurred, and as told by all the speakers, we stress ourselves to the incidents. Once a cop, always a cop. Once a doctor, always a doctor. Once a fragility fracture is there, there is always a chance of second fragility fracture, for which we are preventing. But nevertheless, I will be talking on the other side. The first thing
to intervene,
Right, sir.
surgical aspect, we are keeping some other program. Today we are only talking about medical management. So, is that
right, sir,
over
the
from
people
your end?
are again the juggling with the only 3 drugs. I think I should rest my discussion. And I had prepared for the management, surgical management of.
No, that was not
fine, sir.
the
Right,
topic.
sir.
Okay,
Right,
so thank you very much for your inputs. Now we are going for presentation by Dr. Usha Sriram. Dr. Usha, are you there?
Yes, I am. Yes, I am, sir. I'm
Right.
just sharing my screen.
Please. I think there is some mistake from my side. I should have stopped sharing.
No.
Oh, yes. Are you there? Take your, start playing it.
1 second. I'll share it again. Can you see it now?
Yes.
Okay, I'm trying to make it the full screen, but I'll
Well,
get started. Yeah.
Right. Before Dr. Usha starts speaking, I must introduce her to this orthopedic audience. She is the president of Indian Society of Bone and Mineral Research, and she is heading an institution which is a voluntary medical health services based in Chennai. So with this small introduction, and she is an endocrinologist as well. So Dr. Usha, please.
Thank you, sir, and thank you for your very kind introduction and your kindness throughout this program for me. Thank you. And thank you, Dr. Amarnath, for introducing me to this great group and making me a part of this group. Till Dr. Marwah spoke, I was kind of confident that I was going to talk about non-biologic anti-resorptives and give talk about the benefits of that. He's made such a strong emotional case. I think I'll have to place my case as well. So as far as the non-biologic anti-resorptives, what we have are bisphosphonates. I put it down in red because that's really going to be the crux of my presentation. The others we hardly ever use now. Estrogen, yes, in the PEPI trial and in the Women's Health Initiative, clearly it showed benefit in terms of building up the bone mass and also, hip fracture reduction. But unfortunately, it also comes with side effects like breast cancer and also no real benefit maybe from cardiovascular risk when given long term. So right now we are limiting estrogen to use in women who have premature menopause, taking them up to the natural age for menopause, which is around 50, or women who are after 50 but having a lot of menopausal symptoms and treating them primarily for the vasomotor symptoms, and then could take them up for the next few years. We are not continuing using it as a primary treatment either for managing or preventing osteoporosis at this time, only because Dr. Rajesh Malhotra was in another meeting and we discussed this. The main reason being that following up women when we put them on estrogen with mammography or gynec examinations or other tests that they need becomes very time intensive and money intensive and work intensive, and women may not come back for a follow-up. So that's one of the main reasons in our country. As far as SERMs are considered, they again have been relegated to an occasional use in women, either with a woman with breast cancer and has some bone loss. Using it based on the STAR trial and other things like that. Calcitonin really has not used as an anti-resorptive agent, but only as an analgesic agent primarily. Quick word about bisphosphonates. It's the structural analog of inorganic pyrophosphate, which is the benefit of that because it stays in the bone for a long time, and we are able to use it now, once a year, or even this data coming about using it once in a couple of years or less frequently, but resistant to the enzymatic hydrolysis. So bisphosphonate molecules are able to, through a rigid bond with the hydroxyapatite crystals, to modulate the skeletal turnover, in particular inhibit this osteoclast-mediated bone resorption. And it has been approved for, and the most important differentiating feature is that it causes apoptosis. And even the osteoclasts that don't die and that are still in the bone are become less effective in terms of their osteoclastogenic effect. Approved for use in postmenopausal osteoporosis, male osteoporosis, Paget's disease, osteogenesis imperfecta, hypercalcemia, and bone metastases. It's the use in bone metastases or in oncology that has actually caused some of the bigger issues that we hear about, whether it is the jaw issues or whether it is the atypical fractures. So, like I said, the key target, just wanted to mention that the key target seems to be this enzyme called FEPS. It's a small molecule drug. It induces apoptosis, which is important to keep in mind. Moving on, the main bisphosphonates that we consider are alendronate, risedronate, which are oral, and zoledronic acid, which is IV once a year, and ibandronate. Ibandronate has been used once monthly or every 3 months, but unfortunately, because it has no hip fracture reduction, it's really not part of an armamentarium of endocrinologists. The drugs that we use are only alendronate, risedronate if we are using oral, and oral again have taken a backseat because compliance with oral becomes a very big issue, and people have to sit up, they cannot bend over, they cannot lie down, they have to take it with a glass of water. So all of these things, in almost every country where bisphosphonates are prescribed, the continuation, the compliance, adherence to therapy is very poor, which is what I think has made the IV bisphosphonate, which we give once a year, so popular. And we are able to make sure of the compliance because we give it. And it's also become less expensive now because many of the local companies in our country are making it. We have to infuse it. Previously, it was only available as 4 mg for oncology use. Now we have 5 mg, which is a dosage we should use for osteoporosis, and it should be infused slowly, minimum of 30 minutes or more. If we follow that, the risk of things like even the fever and other flu-like symptoms are less, and people tolerate the drug much more. So this is about the availability of the drugs. And when it comes to therapy now, we've got these anti-resorptives and we've got the anabolics, and each of them having their own, strengths. And I already mentioned the list of anti-resorptives we have. I didn't talk about denosumab or the other ones that are coming up, mainly because I've been asked to limit to the non-biologic, which is the bisphosphonate and estrogen and SERMs and calcitonin. And of them, I'm only going to speak on bisphosphonates because that's all we use in our practice. And I want to show the current recommendation from the endocrine group, and I'll show you in a minute. So major trials have shown the efficacy of these drugs. So it's very evidence-based in terms of both how much bone mass they can build up, and also in terms of fracture reduction, because even if they build bone mass, it's not enough. Ultimately, we have to show in terms of fracture reduction, and in terms of fracture reduction, primarily at the hip. So that is the gold standard when we are assessing these the anti-fracture efficacy of drugs. So as you can see here, all of the 3 major trials I have listed. And I just want to show you pictorially in terms of the alendronate, how did they come up with this dosing of 10 milligram daily or 70 milligram once a week, or what happens with zoledronic acid IV. Now, this is a algorithm that I'd like to discuss. This is an algorithm from UpToDate, which is written by Cliff Rosen and others who are the authorities on osteoporosis, and it is very current. So when we see a patient with osteoporosis, man or woman, we want to make sure that we check their calcium, because we want to make sure there is no hyperparathyroidism, one, that's causing the osteoporosis. The second thing is, if they're already hypocalcemic, and when we give them a bisphosphonate, they can go into dangerous hypocalcemia. So that is a baseline checkup we should do. Second is creatinine, because one of the things where we cannot use a bisphosphonate if the eGFR is less than 30. If the eGFR is less than 30, we have to go with denosumab. So once and vitamin D. There are 2 reasons why we have to check vitamin D. One is if the patient is vitamin D deficient and we give them a bisphosphonate, already bisphosphonate is going to cause some sort of a low bone turnover. And if they already have a soft bone, many of these patients can become profoundly symptomatic with bone pains. And the second reason is, of course, hypocalcemia. So once we have made sure that we have optimized their vitamin D, made sure their creatinine, calcium are okay. So if the calcium is high or low, evaluate for that, like hyperpara and other causes of hypocalcemia. If their calcium is normal, make sure we correct their underlying vitamin D. And then we should give and make sure the eGFR is more than 30. Then if it is not, obviously we have to refer the patient to somebody who is experienced in treating metabolic bone disease in CKD, which is very, very nuanced. And second is making sure that patient, we heard a very nice presentation on, ruling out secondary osteoporosis. So if the eGFR is normal, we really have to consider only one of 2 things, either anabolic therapy like PTH, or let's say we are going to consider bisphosphonate. So if we are considering bisphosphonate, and where would I consider bisphosphonate? If the patient's, let's say their BMD is something that is not more than -3, patient does not have multiple fractures, or if they have not lost bone while on a bisphosphonate therapy, or if they have not had a fracture while on a bisphosphonate therapy, all of these things I would consider as an ideal candidate for bisphosphonate therapy. So begin with bisphosphonates. Do not use oral bisphosphonates if these contraindications exist, achalasia or stricture or varices or Barrett's esophagus, or patient cannot sit up for an oral bisphosphonate. And very importantly, nowadays, history of bariatric surgery with surgical anastomosis in the upper GI tract, like a blue on white bypass. So if all of those are not there, this group recommend oral bisphosphonates because in the US and other places, insurance dictates what we can use, and cost is an important thing. But I personally, in my practice, have moved almost completely, pretty much completely to IV bisphosphonate. And if they have any indications for starting with the anabolic therapy, I would go ahead and start the anabolic therapy and subsequently follow it up with the anti-resorptive therapy. So this is kind of a sequential therapy, starting first the anabolic, following up with an anti-resorptive. Or you first used an anti-resorptive, give some time off, and then give the anabolic based upon how their baseline BMD is. This is how I would manage my patients with osteoporosis. So the contraindications I already mentioned, very important to keep in mind, is esophageal issues, inability to sit up, at risk for aspiration, that's also important. Hypocalcemia should be corrected prior to initiating therapy, and the eGFR. And the thing is, keep in mind many of the esophageal issues that we have to keep in mind. How do we prepare the patient before they go for a bisphosphonate therapy? The biochemical estimation, assess comorbidities that will alter the administration, carefully taking a history, and of course for invasive dental procedures. This is something that we sometimes tend to forget. For both oral and IV bisphosphonates, we must inquire the patient about imminent plans for invasive dental procedures like extractions, implants, discuss risk factors for developing osteonecrosis. It's a very, very rare complication just for osteoporosis management. In patients with cancer or who are on glucocorticoid induced osteoporosis, the risk is higher, or they have other comorbidities. So, and for example, baseline gingival disease and things like that. So it's important that we take a good history. So next question is, how long do we give it? So there's good data for up to 10 years, but usually after 5 years, we can consider a holiday. Actually what we do with IV zoledronic acid is just give it for 3 years. And if they have a stable BMD, no previous vertebral fractures, and who are at low risk for a fracture in the near future, we should consider discontinuing the drug because it stays there for a while. But however, for women at the highest risk for fracture, history of osteoporosis, fracture before or during taking therapy, T-scores, like I said, below -3, or who are taking alendronate or azidronate, you can continue it longer, even up to 10 years, as clinical data shows maintenance of BMD and fracture benefits with no increased risk of adverse events. Here, I just wanted to add one thing. During this COVID time, one of the problems that we had with denosumab was it has to be given every 6 months. And if you don't give it, the patient is at increased risk for fractures. So if they don't follow up, so that's something, an important point that we have to keep in mind. For whatever reason, if patient cannot come back, they're at greater risk. Then if we have discontinued it for whatever reason, for patients in whom bisphosphonates have been discontinued, what you have to do, you typically restart it when there is persistent bone loss, approximately 5% at the femoral neck, or at least 2 BMDs taken at least 2 years apart using the same naked model DEXA scanner. So just an idea of when you can restart bisphosphonates. Is there ever a time when you just temporarily pause the treatment? So suppose a woman has a fracture, or a man, while they are taking a bisphosphonate for less than 5 years, and they have a typical osteoporotic fragility fracture. This group, they say we do not discontinue bisphosphonates because of concern about delayed fracture healing. After all, we are talking about bisphosphonates, suppressing the bone resorption. And as it was mentioned, there is crosstalk between the osteoblast and the osteoclast, and so there could be suppression of bone formation also. So we are always worried about fracture healing. So however, this is not a really major concern. However, in a retrospective study, when they looked at patients with a distal radius fracture, compared with patients not taking bisphosphonates, with those taking bisphosphonates at the time of the injury, they had a longer time to radiographic union in this study. In a bigger study of 19,000 patients with fracture of humerus and all of that, there was no difference between pre-fracture bisphosphonate exposure in patients with non-union and 810 matched controls without non-union. So it is really a clinical decision up to you. You can pause it for a while and then restart it later. Last question, can it be given post-fracture? So again, the recommendation is typically initiate 2 weeks post-fracture, as long as the patient is able to sit up. This is for oral bisphosphonate. But in a big, huge study called the Health Outcomes Reduced Incidence with Zoledronic Acid, the Horizon study, older patients were assigned to receive either IV bisphosphonates or placebo within 3 months of surgical repair. And what they found was overall incidence of delayed healing in the zoledronic acid and placebo groups was similar. And in the post hoc analysis, there was also no difference in non-union rates between zoledronic acid and placebo when it was administered early within 2 weeks. So that's another option that we can give it within 2 weeks. The two big fears that we have with bisphosphonates are atypical fractures and of course the osteonecrosis of the jaw. I just don't want to talk about this to orthopedic surgeons who know most about these complications of bisphosphonates, typically happening in people who receive it for oncology patients and not for the conventional osteoporosis treatment. But there are some early clues like pain or other comorbidities that we need to be watchful for. And actually those arrows pointing to stress fractures. So if we are able to, preemptively look at people who are complaining of pain and making sure they get adequate vitamin D and calcium and keeping patients aware of these potential complications and then they should report to us. And lastly, as it has been mentioned before, the reasons for fractures are so many. While we can treat with anti-resorptive or anabolic, we also need to pay attention to all of these to decrease the risk of fractures. Thank you so much.
Thank you. Thank you, Dr. Usha. After Dr. Marwah's presentation, we are happy to learn that bisphosphonates are still in use, are beneficial to the deserving patients, but you have to look into the pros and cons before instituting this particular drug. Now, all the topics are open for discussion. And before I hand over the discussion part to Dr. Dilip, Dr. Swarnendu, are you here?
Yes,
Dr. Swarnendu Samanta had organized recently Orthopaedic Rheumatology Conference. And it was during the conference, I learned that he has firm views about the use of these anti-resorptive drugs. So can I have some inputs from you, Dr. Samanta?
Yes, it is a Namaskar, sir. It is a privilege to be here in this great platform and with this expert faculty. In our country, probably, I think we'll be taking the opinions from the seniors. We all advocate the bisphosphonates, like my choice is the alendronate. So I the typical fear that probably after 3 years, probably we are going to have the atypical femoral fractures. But nowadays, the recommendation is that we can continue till for 5 years. So what is the view of the other expert faculty, Marwah, Namarnath, and others?
Yeah.
So in your question, you want to have the limitation number of years before you go switch over to drug holiday.
So how long they are the other people they are prescribing the alendronate for like 3 years or 5 years?
I personally would prescribe it for 3 years, at most 4th year, and would be ready to stop it because the patient may not come and might continue because of the advantages that the patient has. So before the 5th year, I will start cautioning my patient from the 3rd year itself, no more for 2 more years.
Can you talk with Marwah, because Marwah has got a...
That is what Dilip said. First of all, because we are on the road of preparing a consensus statement. So first of all, the first question for this should be not the duration, but whether we should use oral or IV bisphosphonates or not. Then we come to the duration. The duration is okay, understood. I also gave it for 3 years, like Dr. Jha. But whether we should use these bisphosphonates or not, put it in the chat box. Put it in the chat box, because we are forming a consensus statement.
I think,
Right.
yeah, as
Yes.
been expressed by senior endocrinologist also, and I've also tried to explain, bisphosphonates are the wonderful drug, safe drug, which should be used, and till data, there is no question that it should not be used. There is some
Manish
other
bhai, that is what I
possibility.
say. Put it in the chat box so that we come to a consensus, a majority consensus. That is
Correct, correct.
Right. Dr. Dilip, now you can proceed with other question and answer. Dr.
Yeah.
Alok Agrawal wanted to say something. Dr. Alok,
Yeah.
are you there?
Yeah, let
I am very much here, sir.
Please.
Thank you.
Go
I
ahead.
just wanted to say that if you heard Dr. Manish saying, when we use biphosphonates, it does not only remove the osteoclastic resorption, but it long-term use decreases the osteoblastic activity also. And that is the limitation why after 3 years, 4 years or 5 years, or as Madam was saying, at 10 years, there will be a fracture because there is no osteoblastic activity. I also wanted to point out the thing that by giving osteoclastic resorption stoppage or this, is there a means of bringing about the bone becoming metabolically active in old age? Why not keep it young with the daily turnover? So some people, and I also have been doing it for the last 10 years, we go for the Arcadian method. It means in the first month, we go for osteoclastic resorptive agent. I use ibandronic acid because it's once a month. The second month, I give a dose of teriparatide that comes 30 to 35 doses. Then in the third month, I give a drug-free period. After 3 months, again, we start the same regimen. And I have found that the people are very happy. They don't get any fractures or any side effects. And we are maintaining the principles also, as was pointed out by Dr. Manish Khanna. And
But
Right. Your accordion. Yes, Swarnendu.
sir, all of the problem is that it is the ibandronate, though it is a very friendly for the patient because the monthly dose. The problem is that it has got no the BMD in the hip fracture. It doesn't make any change. That is the problem. That is the problem with the ibandronate.
that is what I am saying, that it is useful in the hip, or useful in the spine, or useful for other fractures. That is what the company people are promoting in literature. But I am using it for the last 10 to 15 years. And I am finding
sir,
the
I would like to point out a very important thing.
Can I, Manish bhai? Alok bhai, is this your regime or it is a recommended regime from somewhere?
So,
the Rockwood in green is mentioning the regimes.
this regime, which has been mentioned by Professor Alok, is also being utilized and used in AIIMS Bhubaneswar. Now, my question and my solution is, alendronate, bisphosphonate, we are using since almost more than decades. How many of us, good practitioners, have seen pathological fracture? None. Now, this regime is good. Now, the question is, how much fracture fragility risk is there? What you are saying, Professor Alok, is good, but it will take another many years to prove it that it is good. As been mentioned by Dr. Marwah also, definitely, yes, it can be used together, but it should be used in the condition. We can't have a thumb rule altogether. We can't rule it out that bisphosphonate is a bogus drug. It's still the gold standard. But yes, definitely what you are saying, Professor Alok, and what we use
No,
in
I have not said
Bhubaneswar.
biphosphonate are wrong. I am
So
saying it is the
very
first
true,
step
very
in
true. But
making
I
bone
think
metabolically active.
very true. But the consensus, if it's to be formed, it should be formed along to the last 10 decades use, and still the gold standard is bisphosphonate, and definitely has been pointed out by Professor Dr. Shahindu, you have to work it out whether you are treating a vertebral or you are treating a component with the vertebral all together with a hip. In that case, ibandronate is not to be used. But if the vertebral portion is most to be used, ibandronate is right good. Again, it's a bisphosphonate. So
but
I
if
think
you see like this, then most of the people will say that you do serum parathyroid hormone levels. If it is normal or high, then why give the drug? But still you give it because in that dose it makes the bone anabolically active.
So I think it will take many few years to make out with the good publications to prove it in that way.
What about the vertebral fractures? What is your regimen?
Definitely, ibandronate is the best drug for the vertebral fracture if the patient is, in that case. But if you want to go for a surgical intervention in which there is a collapse is there and you want to go for a surgical intervention, better go for a teriparatide for 1 or 2 months and then go for surgical intervention so that osteoblastic activity is sufficiently been increased so as to support that vertebraloplasty or kyphoplasty. But definitely in a non-risk zone, ibandronate is a wonderful drug. It's been expressed and proven wide enough. Oral
any
ibandronate.
experience about the calcitonin?
Calcitonin does not have got any osteoblastic activity, osteoclastic activity. It
In
should
a
not
spinal
be
fractures,
Only,
calcitonin.
yes. I will tell you, it is only in spinal fractures that calcitonin should be used for a limited period of time, only because it limits pain.
Only for the pain, nothing for else. Nothing for else.
Not for that it is helping osteoporosis.
Nothing. It is not helping. It is a misnomer. Medical companies are coming to us. Please don't prescribe for any osteoclastic activity.
And there are reports that on long-term use, there are malignant changes.
True.
So
Yes. We do not use it for a long time.
Right.
But if the patient comes with some sort of compression fracture, even
Right.
10%, 20%,
only for pain.
Given for 3 months, the patients are very much gratified.
Right.
No, but,
Okay. So we have been trying to come out with what is our stand today regarding use of anti-resorptive drugs, non-biological anti-resorptive drugs. Dr. Usha has made a correct judgment and she has said that the results are beneficial. Now, once again, we will like to go back to Dr. Marwah and have his opinion again. Number one, he always quotes International Osteoporosis Foundation 2017 meeting. So first of all, in the last meeting, Dr. Ram has said that the current website of IOF still mentions all these drugs. So any clarifications, Dr. Marwah?
Sir, it mentions all the drugs, but that is not the regime educated. It doesn't mention that this is the drug regime educated. So there's a difference. They are just telling you that these drugs I have this much, but it is not telling that this is the regime educated. And the issue with oral bisphosphonates is that the largest trial done across the world in UK, free of cost, in the late 2005 or 6, the oral bisphosphonates, the maximum uptake of the people was by 14 weeks. Nobody wanted to continue beyond that. And the drug is so slow, it doesn't have any benefit if you use it for 14 to 16 weeks. And none of the trials have shown that it has the patient compliance is there.
And there has been a study about discontinuation of drugs also. They have found that if you take it for 1 year, if you take it for 6 months, results are almost the same. Breaking the protocol doesn't affect the result. Is it right?
Right.
There had been papers on this. And besides, personally, I had been an advocate of zoledronic acid just because the compliance is a problem.
Right.
But what I do a creatinine and calcium level, give injectable of vitamin D initially for 2 weeks, and then I apply it. And again, I'm very watchful for 4 days, looking for any problems. That's all.
Thank you, Dr. Pannag. Dr. Usha,
Yes, sir.
You have rightly said that initially 4 milligram dose was available for oncology use.
Correct.
I always keep on wondering that we orthopedic surgeons are using 5 milligram for intravenous use, zoledronic acid. So what if this, and the oncologists keep on repeating their regime every month almost, because there are secondaries in the articular system. So this 1 milligram difference and this repetition cycle, will you be able to explain little?
So, sir, I think this 1 milligram was more from commercial,
right?
Because they had to, when they had to market
Agreed. Agreed. Yes.
for osteoporosis, they came up with this number,
right.
and they wanted to get the patent for the osteoporosis drug, so they had to get that. But as far as the oncologists using repeatedly, I mean, they are using it for a very different purpose, and you know, knowing the potential side effects from the benefit of using it for the bone mets, I think for them outweighs the possible risk of osteonecrosis of the jaw or atypical fractures. I think that's how they look at it.
Right. Now, suppose we all are in agreement with protest from Dr. Marwah, and we agree that in our socio-economic condition, ideal we cannot use, at least for the economic reasons. You have opined that IV form, that is zoledronic acid, is a better form of administration of bisphosphonate.
Correct.
But in your experience also, when it is given intravenous, 1 in 100, or I can say almost 5% of the patients have very untoward gastric tolerance to this drug, and these patients are those who will look at you as if you have done great injustice to them.
Yeah.
So can we really recognize that this is one patient who will not, whose intestinal tract will be friendly to this drug or will not be friendly?
So, sir, I completely agree with what Dr. Marwah said about the uptake of the oral drug was very poor, and they did that by comparing prescriptions filled in the pharmacies, you know, refilling, and they found very few people were refilling. So it has a lot of reasons. It's everything from remembering once a week treatment and then having to go through that morning routine. And in Indian people, you tell them their coffee has to be delayed, and they feel as if you're, you know, it's a major punishment, even if it's once a week. And so there are many cultural issues also with this once a week treatment. And also our patients have a lot of GI complaints. So a great deal of detailed history taking with about their, you know, GI history, GI complaints, and whether they'll be able to, you know, take this medication. If that is done and they are, you know, enthusiastic, I think only those people, and I would prescribe the oral. And just to tell you, in the last 5 years in my private practice, I haven't used oral bisphosphonate even once.
There you go, sir. See, there you go, sir. That is the proof of the pudding.
Exactly, Marwah sir. I use around 250 vials of zoledronic acid in a year, but I have stopped giving oral bisphosphonates.
Sir, oral bisphosphonates I last used was 2004. After that, I got it.
Now, this is a point that Dr. Marwah made.
Right.
Dr. Marwah, this is a point you made. So, can we conclude this bisphosphonate issue by saying that bisphosphonates are not in the dustbin, but oral bisphosphonates are?
Yes.
Yes, and before instituting intravenous zoledronic acid, I think counseling of the patient becomes important. You have to forewarn them. You will get body ache, you can get some fever, but they are only there for 3 to 5 days. and later you feel much better.
Doctor-
I have occasions when same patient comes back with their neighbor. Doctor, I had few problems for initial few days, but I had great relief. So I have brought this neighbor of mine, give that intravenous injection to this.
Yes,
so this
sir.
also
Yes, sir.
happens.
It is very
This-
good.
this
With
also-
DP sir, Jha sir, Usha ma'am, Marwah sir, can we come to a conclusion on bisphosphonates?
Dr.
That
Usha,
bisphosphonates are an
I-
essential part of the treatment of osteoporosis.
Now, what I will
Yes,
say,
yes.
Not oral.
what I will say, no, we cannot say oral is 100% not to be used. I
Yes,
can
sir.
say preferentially, if
Uh,
possible, because putting in an intravenous may not be possible for a rural orthopedic surgeon.
Dr. Usha, I just want to ask one thing more before moving ahead. When we ask the patient to have oral bisphosphonate and he's compliance, he's taking it, no GI disturbance. Plus, on the other side, a zoledronic acid being given to the patient. Again, there is no problem. Now, my question is, how much you see the rise in the BMD fast with the injectable or with the oral, if the compliance is okay?
So zoledronic acid is clearly shown to be a stronger bisphosphonate, more powerful bisphosphonate. So even for that reason, I would prefer that over the, the only issue is in India, it has not been too much of a problem for us in terms of getting the patient to come to the clinic and having a nurse trained in how to give it. But in other countries, that whole coming to the doctor's office and getting an infusion itself is a production. So for them, just writing off an oral bisphosphonate is easy. So logistically, for many of us, an IV bisphosphonate, as long as we have a trained person, know how long to give it, how to do it, the patient has to be given a prescription for something like a dolo or something for 3 to 4 days, keep it with them. And I actually ask them to preemptively take it every 6 hours to abort the attack. And also to know that in the subsequent infusions next year and following year, it will be much less or none at all. This is more of an acute phase thing that they have the first time and less in the next and less in the next. So once they hear all that, they are more reassured.
Even if the T-score is not bad, it is an early stage of osteoporosis. Even then, you'll prefer to have a injectable zoledronic acid as compared to bisphosphonate oral for another 3 years of time.
So it's like this, the NORA data tells us that more people fracture when they are in the osteopenic range. So,
Perfect.
Okay, so because of the constraints of time,
Yeah.
before we really move into the second part, I have two informations or two inquiries from Dr. Marwah regarding denosumab. Luckily, this is a real wonder drug. It can be used for 10 years. But one point that it treats underlying disease with substantial and sustained fracture relative risk reduction. This is very important, that relative risk reduction of a fracture over 10 years, vertebrae, it gets reduced by 68, 40% in the hip, and non-vertebral 20%. So Dr. Marwah, you agree to this?
Yes, sir.
This is a statistics from Freedom Study.
Yeah.
And the second part of the Freedom Study published in JBJS 2012, that it does not interfere with fracture healing, because there can be a misunderstanding that it will promote fracture healing. So it does not interfere with fracture healing in postmenopausal women. But broad spectrum anti-fracture efficacy is there. BMD rises at 2 years. So this is a very valid point. It will be only at the end of 2 years. And somebody was talking today in some morning webinar that I do not like that BMD is compared between the previous year and the present year. because
Right.
it may not rise so much, and then the patients are very critical. Uniquely improves bone quality, acts on, this again is very important, both cortical and trabecular bone, and definitely synergistic benefits when given with teriparatide is the ideal indication when the fracture risk is very high. So,
Sir,
Doctor,
So, yeah.
yes,
Jha, sir,
please.
can I ask two more questions? One of
Yes,
them may be
please.
sounding stupid, but we need to clarify for the benefit of the general orthopedic surgeons
Right,
all around
please.
the country, sir.
Please go ahead.
This is to Usha ma'am, Jha sir, Dilip sir, Marwah sir, senior orthopedic surgeons. I don't know whether Ravi Sauta sir is here.
Yes,
Is
yes,
there
yes.
any role of anabolic steroids, decadurabolin, that was used for ages and years today in the scenario of treating osteoporosis?
Yes, number one, there is one condition where there is gonadal problem. So there, in fact, it is testosterone which should be used, but these particular group of drugs known as anabolic steroids are just to boost up the general body metabolism. Not very specifically, it has any role on building up bone. Dr.
Okay.
Usha, your comments?
Your comment is perfect, sir. So if there is a hypogonadal male,
It's
just
fine,
talk
man. Fine, man. So the second question. A lady unfortunately develops a carcinoma and has undergone or is undergoing radiotherapy, and she is severely osteoporotic. Do we recommend teriparatide?
carcinoma of where?
A lady postmenopausal develops unfortunately a carcinoma somewhere, and she has undergone radiotherapy or is undergoing radiotherapy. Do we recommend teriparatide in that?
No, sir.
No.
100% no.
Actually, the literature is saying it don't give because it promotes malignancy. It is a contraindication to teriparatide.
Then again, intravenous bisphosphonate, the zoledronic acid, should be advocated to the best
These
of
are
my
important
knowledge.
points to be noted. Important points. I rest my this thing.
Dr. Marwah, you agree to this?
Yeah, I agree with you, sir. 100%.
Yes.
100%.
And
Right.
here it is not once yearly, it is every month they give to prevent
Right.
fractures.
Any other question?
Yeah, in pathological fracture also in tumor cases, pathological fracture into the long bones, and operation has been done. So what should be the anti-resorptive measures that you will take? Is it intravenous?
Yes, your question should be anti-resorptive should at all be used.
Yeah,
Either biologic or non-biologic.
non-biologic.
Or you will switch over to, and then you have to say, this
Yeah.
is a pathological fracture of a cortical bone,
Yeah,
or a neck of the femur.
long bone fracture
Right.
because of secondary deposit.
No, because of secondary deposits, then again,
Yeah,
bisphosphonates.
yes,
yeah.
intravenous.
And one thing, Dr. Marwah, actually, are Marwah available?
Yes, yes.
Yes, you have got this very good slogan, build the bone, freeze the bone.
G.
So what is actually the combination therapy that you have advocated about the fragility fracture of para-PTH and the demosimod? So is there any role in these conditions that actually our Atul has also told about the pregnancy, postmenopausal, and there is this radiotherapy going on, or in case of the pathological fracture to the long bone? How can this be useful in our country, in our scenario?
Sir, in a pathological fracture of any malignancy, with or without radiotherapy, we cannot use teriparatide.
Right.
Use zoledronic acid, 5 milligram or 4 milligram. That's what the oncologists use all the time, as many times as required, but not teriparatide, sir.
Not the therapeutic.
So with constraints in time, Dr. Dilip, we need your permission to for your concluding remarks.
Yeah.
And the remark number one I will define is that non-biologic anti-resorptives are not out, maybe on the verge of being out, but for our Indian subcontinent, I would say you have to take your own decisions. Some of the decisions will be guided by subsequent talk in topic number, in second heading.
And second part, yeah.
Right. Anything else you want to say, or you will hand over back?
Yeah, just one line I like to say to Usha madam, because she is new to our fold. And Usha madam, the band master of the orchestra. Endocrinology is nothing but the band master of the orchestra, and has got the control over all the activities of the therapy. So, what is your last line or advice to the treating orthopedic surgeons with osteoporosis? Primary, not going to the secondary, primary osteoporosis.
How they should treat it?
How will you proceed with that? All orthopedic surgeons.
So I think
we'll go for investigation first. We'll go for this analysis of your endocrine analysis, or anything that you like to advise us.
So very basic investigation, like I mentioned, calcium and creatinine and vitamin D, that's very, very important, because that itself will rule out most of the serious things we are thinking of, hyperpara and osteomalacia due to vitamin D. Once that part is done, then it's also easier for us to go ahead and treat. I still strongly believe that we should consider not in very poor. If it is very poor bone density or multiple fractures or previous treatment with all of those conditions, go straight with teriparatide. Otherwise, go with bisphosphonate. And then I don't do combination. I do sequential therapy.
Right.
Right.
Thank you.
So, thank you. Thank you, Professor Jha.
All the previous speakers are requested to be present till the end, because we may like to have inputs from them. So, Dr. Usha, you are also requested to remain.
I'll be there, sir.
Right. So, we are talking about secondary osteoporosis, and there are congenital conditions regarding our young friend. Dr. Mohit will be talking about diet, various drugs, endocrine disorders, systemic and renal disorders, and especially respiratory disorders like COPD and asthma, where steroid is regularly prescribed, including rheumatology disorders and GI disease, in which gastrectomy, primary biliary cirrhosis, etc. are there. So they all can be responsible, including renal diseases. So now I hand over the topic to Dr. Jayaprakash Tiwari, Professor Jayaprakash Tiwari, who is Professor and Head Department of Nephrology, Goa Medical College, Goa. Thank you very much, Professor Tiwari, for coming to this group of orthopedic surgeons. So your talk now. I will stop sharing. Yes. Please.
Can you see, sir? It's visible?
Yes, visible and audible, both. Time is 5-10 minutes. You have 8 minutes to go. Right.
I'm going to talk about the secondary osteoporosis in the renal disease. Osteoporosis and another common bone disease, especially occur in chronic kidney disease apart from the renal osteodystrophy. The severity and the treatment of the osteoporosis varies in different stages of chronic kidney disease. So we have to know about the stages of chronic kidney disease, which depends on the eGFR, abnormal filtration rate. Stage 1 is more than 90 ml per minute of GFR, and stage 5 is less than 15 ml per minute per 1.73 meter square body surface area, and that is end stage renal requires dialysis and transplant. Diagnosis of osteoporosis early stage bone mineral density, and in late stage, stage 4 and 5, you have to exclude the mineral bone disease with laboratory test and sometime bone biopsy. The laboratory assessment in early stage have to take the history of fragility fracture or low bone mineral density, the T-score less than 2.5. Apart from that, we have to do the serum calcium, phosphorus, PTH, vitamin D, and alkaline phosphatase. But in the late stage, stage 4-5 CKD, bone-specific alkaline phosphatase, in addition to the above investigation, is required to be considered, assuming there is no coexistence of renal osteodystrophy. Bone biopsy in special cases is required. Assessment of bone fracture, as already discussed by most of our colleagues, like in stage 1 and 3B, and risk factor for the fracture, bone mineral density testing to assess the fracture. But in the late stage, in selected patients who have fragility fracture and no evidence of mineral bone disease, particularly when osteoporosis therapy is being considered. Medical management, lifestyle measures, everyone speak about, but calcium and vitamins D supplementation is very important. In early stage, up to stage 3, 1000 milligram calcium, but in stage 4-5, late stage target calcium intake is 1200 milligram per day, and vitamin D along with 800 international unit daily. Hypogonadism treatment is very important. For hypogonadal premenopausal women with CKD, chronic kidney disease, and low bone mass or fragility fracture, oral contraceptive, if not contraindicated, or estradiol or progestin replacement therapy is required. For men with chronic kidney disease, osteoporosis, and symptomatic hypogonadism, testosterone therapy, if not contraindicated. For oncological therapy, in early stage and no evidence of CKD, mineral bone disease, choice of pharmacotherapy is similar as for patient without chronic kidney disease. No change in the dosing in patient with early stage where GFR is more than 30 ml per minute, either abitronate, zoledronic acid, or acidronate. In stage 4-5, with evidence of fragility, no evidence of fragility fracture, do not treat with pharmacological therapy. But in late stage, stage 4-5, with evidence of mineral bone disease, with fragility fracture, consider pharmacological therapy, but exclude other forms of the mineral bone disease like osteomalacia, fibrosis cystica, and adynamic bone disease. In late stage, oral bisphosphonate or injectable bisphosphonate and denosumab is an alternative option. Stage 5 CKD, oral bisphosphonate may be considered, decidonate 35 milligram every other week, 1/2 of the usual dose, and for not more than 3 years. Denosumab is an alternative and safe option. Bisphosphonate not routinely recommended if GFR is less than 30 ml per minute. Useful in patients with high turnover bone disease. Generally, it's contraindicated. GFR is less than 35 ml per minute. A high incidence of osteoporosis of the jaw, esophageal cancer, fracture occur in patients receiving intravenous bisphosphonate for a longer period. Denosumab, as we know, the potent anti-resorptive agent, no risk over suppressing bone turnover due to drug accumulation in the CKD, unlike bisphosphonate, recommended for the management of osteoporosis in the early CKD and also safe in the late CKD. Denosumab administration in hemodialysis patients have association with clinically significant hypocalcemia. So one should look for the hypocalcemia in patient on dialysis. Riloxifan can be used at any glomerular filtration in late stage also and seems to be effective in improving the lumbar spine bone mineral density in post-menopausal women with end-stage renal disease, used for prevention and treatment of osteoporosis in post-menopausal women. Terapeptide that already discussed about is dose 20 microgram per day by subcutaneous in patients with low turnover or adynamic bone disease. These agents may increase bone turnover and results in increased bone mineral density. Romosozumab is sclerostin inhibitor, limited study in chronic kidney disease patient till date. Patient with in post-transplant period with first 12 months after kidney transplant, if GFR is more than 30 ml per minute and low bone mineral density, vitamin D and anti-resorptive treatment agents are recommended. But in late stage of the CKD in post-transplant, low bone mineral density management as for patient with CKD not on dialysis, the same regime have to use. It is reasonable to consider bone biopsy to guide the treatment. There are insufficient data to guide treatment after 12 months of the post-transplant period. Manage of chronic mineral bone disease. Apart from the osteoporosis, we have always ruled out the mineral bone disease in chronic kidney disease before starting anti-resorptive therapy, other treatment for the osteoporosis, like osteomalacia, adynamic bone disease, osteoarthritis fibrosa, cystica, and treatment is hypocalcemia is common. You have to treat hypocalcemia with calcium, vitamin D, and one thing that you can in patient on dialysis, you can increase the calcium in dialysis consent between 1.25 to 1.5 millimole per liter. Dietary phosphorus intake should be restricted. Hyperphosphatemia is common in these patients leading to the fracture. So you have to decrease to the 800 to 1000 milligram per day. Other phosphate binder like sevelamer, sucroferric hydroxide, lanthanum carbonate should be used to decrease the phosphate level in these patients. Hypervitaminosis D, you have to use the in stage 3-4 patient, the secondary hyperparathyroidism, you have to use the vitamin D, different dosage in different level of the vitamin D. Metabolic acidity is the major problem. Decrease the calcium absorption in the renal tubule. We have to treat the metabolism. Oral sodium bicarbonate. Initial dose is 1 to 2 grams twice or thrice daily. Varumar is a promising new drug in the treatment for the metabolic acidosis in these patients. Secondary hyperparathyroidism is a major problem due to the hypocalcemia, low vitamin D in these patients, and should be treated in the late stage with vitamin D analog. The level of the vitamin D and dose you have to monitor in these patients. If patient had hypercalcemia, with hyperparathyroidism, we should not use the calcium, we have to use the cinacalate. That decrease the hyperphosphatemia, hypercalcemia, and limit application of vitamin D in these patients. Initial dose 30 milligram per day and titrate to 2 to 4 weeks interval up to maximum up to 180 milligram per day. Parathyroidectomy, if patient not responding to the calcium, vitamin D, hyperphosphatemia treatment, and cinacalate, there is required the parathyroidectomy, secondary hyperparathyroidism. There is a biochemical and clinical criteria to go for the parathyroidectomy. Diagnostic test, there is one thing in young patient coming to the orthopedic surgeon with the deformity in the lower limb, rickets, always rule out the congenital anomaly causing chronic kidney disease. And you have to treat for those conditions. Most common, the renal tubular acidosis, we should look for the urine pH, ammonium chloride test, and depending on the type of ITA, you have to treat. Metabolic acidosis is the major problem, should be treated the sodium bicarbonate or potassium citrate, and newer potassium binder in type 4 ITA is peritomer and sodium zirconium is very important. Congenital anomaly always rule out in these patients the renal agenesis, multisystem disease, vascular reflux, posterior urethral valve, leading to chronic kidney disease and renal osteodystrophy before starting osteoporotic treatment in these patients and treat accordingly. Nutritional vitamin D deficiency is the most common cause of the ricket, but genetic cause include classic hypophosphatemic rickets, FGF23 related, Den disease, Fanconi syndrome, renal tubular cirrhosis, and vitamin D dependent rickets in these patients should be treated. Conventional treatment for patients with X-linked hypophosphatemic rickets consists of multiple dietary dose of inorganic oral phosphate salt associated with vitamin D analog, namely calcitriol, should be used. Burosumab seems to be novel, safe, and effective treatment for children and adults with X-linked hypophosphatemic ricket. This treatment requires a multidisciplinary approach. Thank you. Thank you very much.
Very good talk. Thank you.
Thank you, sir.
So, Professor Jha.
So your mic is muted. Your mic is muted.
Tiwari.
Yes.
Yes, you are here.
Yeah, we are listening. Yes, Muzumder sir, you take over.
Yeah. So this was from very nice talk from Goa, from our Tiwari sir. Another Tiwari is here, who is our stalwart. So sorry. So all this now we will go for Jha, Professor Jha. Then we will come in the question answer. We will ask something to Dr.
Right.
Tiwari.
Thank you, Dr. Manish and Dr. Dilip, for inviting me for this lecture, Glucocorticoid Induced Osteoporosis. At the very outset, I must say that this is the most common form of secondary osteoporosis, and it is the first cause of osteoporosis in young age, which Dr. Mohit will subsequently tell you. Well, these are some of the situations where the patient have been on glucocorticoids, including COPD and asthma, rheumatic diseases, and even Cushing's syndrome and diabetes in itself. So how do we manage? And the management has been divided as per age, more than 40 years and less than 40 years. Let us first of all talk about more than 40 years. So let me ask a question to myself. Patient on glucocorticoid therapy and the age is more than 40 years. When should osteoporosis medications be instituted? Friends, the answer is that you should start your treatment basing on risk stratification. So what is the kind of risk? It is low, medium, or high risk. And you have three inputs. One is glucocorticoid adjusted WHO FRAX tool. All of us have heard about WHO FRAX tool. Subsequently, you will learn about how it is adjusted with glucocorticoid dose. Second is lowest T-score value. It is lowest T-score, remember. And third is history of fragility fracture. So based on these three, we find that it is a low-risk patient, so no further treatment is required. Monitor with yearly clinical fracture risk assessment with BMD testing every 2 to 3 years, depending on risk factors. To the Ortho TV team, I will request not to stop the recording. Ortho TV team, somebody is there? Dr. Atul, will you see to it that it is recorded? Right.
It is being recorded, sir.
Okay, fine. So low risk, even if you are performing BMD, you have to do it every 2 to 3 years, not very early. Now, if it is a medium fracture risk, so when it will happen, if the patient is on prednisolone or prednisone, 7.5 milligram or more dose per day. And now, how do we calculate it against the dose? So first of all, try to get the fracture risk and multiply it by 1.15. So this is the adjusted value for that glucocorticoid. This is the major osteoporotic fracture for 10 years. And if you multiply it by 1.2, it will give you for hip fractures 10-year fracture risk. Average comes up to 10 to 19, you can say 20%. And the major osteoporotic fracture and for hip fracture, it is 1 to 3%. Now see, high fracture is prednisolone dose more than 30 milligram or 30 milligram per day, or in the last day, the patient has totally taken 5 grams. So this is high frax risk, and it is 20% major osteoporotic fracture or 3% hip. The T-score, if it is lower than -2.5 at any site in a postmenopausal woman, sees a high fracture risk. Any man aged more than 50 years with these parameters and history of previous fragility fracture. Now, a second question, what are the medications which are effective in patients on glucocorticoid therapy after age 40 years? There has been significant improvement in BMD and reduced fractures in controlled trials by using bisphosphonate. It includes, apart from alendronate, risodronate, also IV zoledronic acid, and of course, denosumab and teriparatide. Now, coming back to less than 40 years of age. So see how the parameters change. Here, the risk stratification depends on history of prior fragility fracture. It is not the minimum T-score. It is the Z-score which is very important. And what is Z-score? Compared to the same age, normal healthy adult. The dose of prednisone and bone loss as studied by DXA scan. So these four things will tell us that the low-risk patients are those who have no risk factors other than being on prednisone. Like a patient of rheumatoid, you have just started prednisone. Medium risk is spine or hip Z score is -3 or less, or 10% decrease in BMD. You will ask me, how do you know 10% decrease? In subsequent slide, you will get the answer. So 10% decrease in BMD in 1 year and continuing on prednisone more than 77.5 milligram per day for more than 6 months, or high dose prednisolone exposure, that is 30 milligram or more per day, and the total dose is more than 5 gram in last year in patient aged more than 30 years. Pediatric patients, Dr. Mohit will tell you, and high risk must have a prior osteoporotic fragility fractures. Now, what are the therapeutic guidelines for a pre-menopausal woman with childbearing potential with previous fragility fracture? Dr. Atul was also asking this particular question. So treat only if she is continuing on prednisone. Oral risodronate theoretically is the safest oral drug. Other bisphosphonate, safest oral bisphosphonate, and it has potential of less fetal toxicity in possible pregnancy. So patient, here is this information. Risodronate in pregnancy has less fetal toxicity and so is comparatively safe. The other alternative is teriparatide during pregnancy. Here is no malignancy. So either risodronate or teriparatide, and caution, denosumab is contraindicated in pregnancy. Another question, what is the guideline for patients on intermittent pulses of IV glucocorticoid or maybe even oral glucocorticoid? Well, there are no answers in the literature, but high-risk patients receiving 4 or more monthly IV pulses. And what is that IV pulse? 1 gram methylprednisolone or equivalent, or 4 or more high-dose oral pulses consisting of prednisone 60 milligram or more per day with taper over 2 to 4 weeks. So within a 12-month period, as per risk stratification laid down, and that I have discussed just now. So pulse therapy, pulse glucocorticoid therapy is also guided by risk stratification. Another question, probability of bone loss on prolonged inhaled steroid. Suppose the patient has asthma. So he or she has been on prolonged inhaled steroid. So on daily inhaled steroid, which becomes equivalent or higher dose than 200 mg per day for a prolonged period of time, that is 20 years, they can lose bone. And here is the formula. What is that formula? If there is loss of 1 T-score, loss of T-score by 1, it is 12% bone loss. So we have to periodically monitor these patients. So friends, to conclude, the management take-home message is that the management is based on risk stratification in low, medium, and high categories in both age groups above and below 40 years. Glucocorticoid adjusted WHO FRAX tool, lowest T-score value, and history of fragility fracture determine the factors above age 40. History of prior fragility fracture, not T but Z score, prednisolone dose, and bone loss by DEXA scan are determining factors below age 40. Bisphosphonate, denosumab, teriparatide claims significant improvement in BMD and reduces fractures in control tires for age above 40. For age below 40, either starting or currently on glucocorticoid with anticipated duration of therapy of 3 or more months. Low risk patients give oral bisphosphonate. Medium and high risk patient, again, bisphosphonate, denosumab, and teriparatide. Teriparatide is to be preferred, as told earlier, in anticipated pregnancy, or if the Z score is lower than -3 and there is a history of fragility fractures. Thank you, friends.
So thank you, Professor Jha, for your elaborate 7 points. Take home message, very nice. Okay, so
Right.
you will learn a lot of things about Z score also. Now we will go for the pediatrics.
Right.
Mohit Arora,
Yes, sir.
because pediatric osteoporosis is again a new thing, not a new thing, it is an old thing, but fragility fracture occurs in children also. So Mohit Arora, be concise and brief to your time, because we are running short of time now.
Right.
Right, sir. Right.
Mohit is all prepared for a brief presentation. So sorry, Mohit, I have to stop share.
Yes.
Right, please. Yes.
Right. So is my slide visible, sir?
Yes.
Yeah, nice.
Basically, my topic is pediatric osteoporosis and fragility fractures in children. So the aim of this presentation would be definition of the pediatric osteoporosis, the causes, the diagnosis, treatment, and the recent advances. Now, as per International Society for Clinical Densitometry, pediatric osteoporosis is defined as the presence of one or more vertebral fracture in the absence of a local disease or a high energy trauma, or a Z score of less than or equal to -2, and history of clinically significant fractures, which involves specifically 2 or more long bone fractures by 10 years of age, or 3 or more long bone fracture at any age up to 19 years of age. Now, it has been classified into 2 types, primary and secondary osteoporosis. Primary is mainly genetics, which includes osteogenesis imperfecta, Marfan's, Ehlers-Danlos syndromes, homocystinuria, idiopathic juvenile osteoporosis. Now, the more common secondary osteoporosis that we are interested in is clinically include nutritional intestinal malabsorption disorders like vitamin or mineral deficiency, inflammatory bowel diseases like celiac disease. Then neuropsychiatric causes, cerebral palsy, spina bifida, myopathies, Duchenne muscular dystrophy, spinomuscular atrophy. Then inflammatory diseases like juvenile idiopathic arthritis, SLE. Then secondary to therapies, which has already been discussed by Professor Jha sir, glucocorticoids, anticonvulsants, chemotherapy, post bone marrow or solid organ transplant. The less common causes include endocrine disturbances like growth or sex hormone deficiency, Cushing syndromes, hematological disorders like leukemia, thalassemia, and in the end, chronic kidney diseases. Now, investigations, Dr. Vikas Jain will be discussing in details, just include calcium alkaline phosphatase, phosphate, vitamin D level, serum PTH, 24-hour urinary calcium, and DEXA scan. Now, as per ISCD, any child being treated or considered for the treatment of osteoporosis should undergo a DEXA examination. The indications as per National Osteoporosis Foundation includes patients on long-term steroids, chronic inflammatory conditions like celiac disease, hypogonadism, prolonged immobilization, and other causes of the secondary osteoporosis. Now, the sites of DEXA include anterior, posterior lumbar spine, femoral neck, trochanteric or total hip region, and proximal femur in case of children who have reduced weight bearing, and dilated distal femur in non-ambulatory patients. Bone markers, they are more commonly used in adult osteoporosis, including osteocalcin and beta cross-type. I think we'll be discussing it later on. Vertebral fractures are the earliest sign of pediatric osteoporosis. They are often asymptomatic. Hence, a spinal fracture surveillance is required for early intervention and includes spine imaging. Now, predictors of vertebral fractures include long-term use of corticosteroids, immobility, delayed puberty or pubertal arrest, chronic inflammation, back pain, reduction in spine BMD Z-score, thalassemia with frequent transfusion in children older than 10 years. Now, points to consider when assessing treatment or potential for recovery are: if there are greater number of fracture or more degree of compression, then urgent treatment is required. If the remaining growth potential is less, then also urgent treatment is required. If the likelihood of persistent risk factor remains, then the treatment is required. However, after the persistent risk factor they go away, then no treatment is required. Now, as far as treatment is concerned, apart from calcium and vitamin D, bisphosphonates are the only treatment recommended for in case of pediatric osteoporosis. Now, this is a paper which said that risentonate is the most potent oral bisphosphonate in children with moderate to severe osteogenesis imperfecta. Now, this is a treatment approach I have picked up from Therapeutic Advances in Musculoskeletal Disease 2020. So basically, they've divided, they've used zoledronate in case of children with osteoporosis, and they've divided the patients into 3 categories. The first one is disuse osteoporosis, second is cerebral palsy, Rett's disease, and other neurological condition, not the muscle disorders. So in that, they say 2 years of full dose every 6 months, that is year 1 and 2. Then after 2 years, you give half dose every 6 months, and then after that, you give 1/4 of dose every 6 months. Then the second group, they have divided it into primary bone fragility like osteogenesis imperfecta, or muscle disorders like DMD, or hematological disorders like thalassemia and sickle cell anemia. In that case, they only advocate treatment to full dose every 6 months until the age-adjusted bone marrow density is more than 0 standard deviation. If it becomes more than that, they give half the dose every 6 months. And if it becomes more than 2 standard deviation, you give 1/4 of the dose every 12 months. Now, the third condition is where the underlying condition is controlled or treated. So basically, in that, the treatment is always customized, and they should get a full dose every 6 months, but the duration is customized as per the continuation of steroid treatment, their bone marrow density, pubertal status, and the underlying condition. Now, before each infusion, we have to make sure that calcium and vitamin D is normal. As Professor Alok Agarwal also pointed out, that osteoporosis treatment without getting normal vitamin D and calcium is of no use. And renal function tests before starting bisphosphonate, they should be ensured they are normal. Then all the patients are admitted for the first infusion, which is the half dose, and continued with the full dose at the day unit for the subsequent one. Prophylactic paracetamol to mitigate pyrexia, aches, and pain, and treatment is stopped once the skeletal maturity is achieved in all the 3 groups. The doses, as per the authors, is for children less than 2 years, it is 0.025 milligram per kg, and 2 to 5 years is 0.035 milligram per kg, and if they are more than 5 years, then it is 0.05 milligram per kg. Now, these are the symptoms which we have already discussed, and we can use paracetamol. Now, there is another paper by Bourimes and Trejo et al., which shows that a pattern of stress fracture in femur was related to severity of osteogenesis imperfecta rather than bisphosphonates. So, the stress fracture is very, very rare, especially in cases of pediatric osteoporosis. Now, for the children who are on anti-resorptive therapy, we see the line of calcification. These are metaphasial sclerotic lines, which are called zebra lines. They can be seen very frequently on X-rays. Now, pamidronate therapy has been associated with delayed healing of osteotomy site. Hence, we have to be sure that once we are doing a corrective osteotomy in cases of children with osteogenesis imperfecta, we have to maintain a bisphosphonate pre-interval. Otherwise, the healing will be delayed. And once we see adequate callus formation, then only we can start the next dose of the pamidronate. Now, denosumab, which is more common in adult osteoporosis, has been used in children with OI, in other conditions also, giant cell tumor, Paget's disease, DMD, fibrous dysplasia, and it is still in trial phases in some cases of pediatric osteoporosis. Now, anabolics, there is a role of anabolics in case of patient with growth hormone deficiency. We can give growth hormones. They are better than giving bisphosphonates. Now, cases of delayed puberty, it is always better to give testosterone. Now, parathyroid hormone should not be used in the children as there is a theoretical risk of osteosarcoma when their growth plates are still open. Now, there are more model treatments like anti-sclerostin antibodies. The glycoprotein sclerostin is secreted by osteocytes, which inhibit bone formation. So, pediatric trial is going on, and adult studies have shown promising results. Now, another one is anti-tumor growth factor beta therapy, of which losartan is an ACE inhibitor that downregulates the TGF-beta signaling and have shown a potential use as a treatment for osteoporosis. Now, the last one is whole body vibration therapy. It is based on mechanostat theory, which says that bone adapts its strength to mechanical forces that are mostly imposed by muscles. Hence, any treatment that strengthens the muscles should lead to improvement in bone structure and mass, mobility, balance, and risk of falls. Hence, the whole body vibration strengthening the muscle can be given in case of pediatric osteoporosis. Now, I conclude my slides by saying that management of children with osteoporosis, requires a multidisciplinary approach, which involves a team of healthcare professionals, including pediatrician, orthopedicians, those who have expert on pediatric bone disease. Thank you.
Thank you.
Thank you very much, Dr. Mohit. And now is the last presentation by Dr. Jain. Dr. Jain, are you there? Dr.
Yes,
Jain, yes, you are there.
We don't have the spine presentation.
Okay, so
yes, we have a spine presentation.
I wanted Dr. Jain to speak about his topic, and then we will have his spine.
Okay,
right?
okay. I'll do that. We'll do that.
Vikas has got a topic. Yeah.
Right.
So wait a minute. I will have to share the screen.
Yes.
By that time, Vikas, it's a pleasure sharing the screen with you.
Can you see the screen?
Yes. Visible, audible, everything.
Yeah, it is very nice and has covered whole of the screen.
Okay. So can I start, sir? Atul, sir, you wanted to say something?
No, Atul will say one or two words. Please.
Dr. Atul.
No, Dr. Vikas, please.
Okay.
So, very good evening to all of you. I come from the part of Gujarat that is heavily raining presently, and I have been watching all esteemed panelists with lovely inputs that they have given, and all kudos to the IOA team and the IORA team. Friends, I'm talking on the tools which will be required in order to approach osteoporosis. You know, it is very really nice to see now orthopedic surgeons getting themselves intrigued by the idea that we should think in terms of prevention and early detection as far as this deadly silent bone disease is concerned, and we all understand why. So there is a confusion, there's a conundrum, you know, because if you see 99% of the challenges that we as an orthopedic surgeons get in our day-to-day practice arise from osteoporosis, while hardly orthopedic surgeons or even 1% are interested in order to understand fragility and to prevent fragility fractures. Going to the investigations or the tools, there's an entire buffet of tools which are available, but however, we should come up with the right guidelines as to which tool to use when, so that there is no confusion, and which is the best tool and which is going to give us the best way in order to approach all types of osteoporosis. Why do we need these tools? Because as you know that the disease is very silent, and the entire community, most of them are unaware of that disease. So we should be able to have an idea about what is the stage that the person who's coming to you as a patient is in. As far as osteoporosis is concerned, we should be able to rule out whether it's a primary or a secondary osteoporosis. We should also be able to judge whether it's a low turnover stage or it's a high bone turnover disease. We should also understand whether we would be treating the patient only by lifestyle management or would we require pharmacological management? Because if we go, we require to step by step approach the osteoporosis, and hence accordingly we would be able to give a judgment as to, and we would be able to either prevent, early detect and treat if required. Which is very important is we should reduce the occurrence of fragility fractures, and if there is a first fragility fracture that has happened, then we should not allow the second fragility fracture to happen. This is very important for every orthopedic surgeon to understand. As every one of you have been talking, the history is one of the main tools. The patient who walks to you, the way he walks, you take all the history about the patient. You look about the patient, about his height, his weight, about his history, his personal history, about alcoholism, about smoking. Try to find out about whatever disturbances that he would have, what are the metabolic disorders he could have. Is he having any form of a cancer? Is he taking any chemotherapy? Has he been taking any steroids? Because we are in a post-corona age where a lot of patients who have been treated for corona have taken steroids, and that is affecting the patients. We should look at the age, the gender, as well as the race. So apart from that, what are the tools? The radiographic tools which are available, you can start with X-rays. DEXA is available. You have quantitative CT which is available. MRI and bone scans are available. FRAX is another very important tool which many of the orthopedic surgeons and the other medical professionals are looking at, with or without DEXA. Friends, if there is anything to do with bone turnover, definitely there would be serological and urinary markers. If you can trace that, and then you have something known as a biopsy, which can be helpful in very few conditions. If you look at the radiography, what is more important, because radio X-rays cannot be the diagnostic tool for osteoporosis per se, but we as an orthopedic surgeons are the most competent people to look at the X-rays, and hence it should be giving us a fair idea in the very early stage whether there is a loss of the trabecular bone, whether the cortical bone is intact. In the lumbar spine, predominantly the DL spine, you should be able to see whether there is wedging or whether there is loss of height. Now, these are very important things which you can just preliminarily make out on an X-ray. If you talk in terms of a DEXA, most of you are aware about what DEXA is. This is considered to be gold standard. However, there are a lot of discussions whether the availability of DEXA is there or not, whether the person who does DEXA, the technician, is right or not, and hence, however, let us understand that presently this is the best tool that is available for us to have a fair idea about what is the quality of the bone that the person has. If you do a BMD using DXA, you would get a rough, not an absolute volumetric idea, but if you are used to look at DEXA, you will get an idea about what is the grams per centimeter square of the bone at the neck level, at the lumbar spine level, which is available. Friends, if you keep on studying that, you get a fair good idea about what is the loss or what is the state of the bone loss that the patient has, because this helps you then to decide whether you want anti-resorptive agents or whether you want to start anabolic medication. We are aware about the T-scores, and the T-scores, we should be very importantly understanding that for every loss of one single standard deviation, the risk of fracture doubles. Now, this is the most important thing that we as orthopedic surgeons should understand. The T-scores, as shown, you should know what is important. Let me tell you at this stage that the osteopenic stage is very important. For a postmenopausal or a perimenopausal, there's a study which says that around 70 to 80% of the women who are in their menopausal age, they fall in the osteopenia range. And even if you have not done a DEXA, that study should give you a fair indication that you should start with some form of management, because this female who is in her menopause will then subsequently go on to increase her risk of fragility fractures. As far as Z score is concerned, it has been discussed by various panelists that it is a comparative score pertaining to that particular age. As I already mentioned, that for a standard deviation which reduces by 1, the fracture risk increases by 2 times or maybe around 3 times. Half of the osteoporotic fractures that occur in women with T-score greater than -2.5. Now, this is very important. We should understand, as I have previously mentioned, about the osteopenic range, which is what we should understand. If you see the advantages that DEXA has and there are disadvantages, it has been discussed that the problem lies that it is not easily available. It's not totally volumetric. You have to always use the same technician, same machine, so that you, when you get a repeat DEXA done, you rely on the parameters which are coming out of it, and then false high you could get with certain conditions of spinal fractures, osteophytes. However, still it is a belief that this is a cost-effective, low radiation way in which you can get a good idea about the stage and the quality that a particular person or a patient has as far as osteoporosis is concerned. These are few measurements which are not used and which are not known to many of the orthopedic surgeons. Few of the DEXAs have got HSA, which gives us a fair idea about using the parameters around hip. It gives you an idea about the possibility of a fracture in future. Similarly, for a lumbar spine, you have TBS, which will give you the measurements. However, finite and element analysis is another algorithm-based futuristic, wherein they create a 3D model and they give a simulation, and the forces which can break a particular hip is what is decided on FEA. Now, this is something which is not commonly available, and it is all on the research stage. So we don't much focus because we should know what is the basic DEXA. Frax is something which we should all, and we are all using. It's the WHO has come out with it to give us a 10-year probability in a man and a woman as far as the fracture risk is concerned, because it is very important for we as an orthopedic surgeons to give an assessment as to what is the possibility. So this has got very simple parameters. You have to go again by the history. You can take the age, sex, race of the patient, height, body mass index. You have, most important is steroid or glucocorticoid history, whether there is a parental history of a fracture or whether there is a history of a fracture that the person himself had, or rheumatoid arthritis. Even alcoholism and smoking would add to the risk, and accordingly the Frax has an algorithm which will calculate the risk at the hip as well as the major bones, and they have come up with a score where even if without doing a DEXA, you will get a score through that algorithm, wherein you would be able to find out whether the patient is at the 10-year risk of that patient. Now, if you see the 10-year hip fracture risk of anything more than or equal to 3%, or a 10-year risk for other major osteoporotic related fracture for more than or equal to 20 is what is important for us. That should ring the bells. If you see in this comparison, you will find that all those who had no risk fractures had a minimum 10-year fragility risk, while as you keep on adding a family history or a steroid or a history of prior fracture, you can see how much the 10-year probability increases in the Frax. This is what is very important for we as an orthopedic surgeon to understand. If you see the bone turnover, because it is very important for us to understand that the bone is a dynamic tissue, there is a continuous breakdown and laying down of a new bone. However, in an abnormal condition, either there is an increased osteoclastic activity which becomes a high turnover state, or there is an increase in the osteoblastic stage and there is a lowering in the osteoclastic, but osteoblastic also gets lower. That comes in the low turnover stage. Now, all this in a condition where such changes that are happening at the biochemistry level you would have certain bone markers. I will come with the table on the bone markers, but important for us to understand is that this bone markers, which are biochemical bone markers, as far as the
Dr. Jain, will you conclude? Will you please conclude?
Yeah. So once you know these are the important bone markers which are available, then most important use of bone markers would be just to understand the effectiveness of treatment. You cannot predict a risk or you cannot use it for treatment. Then there are various other serum markers. Most important them we would be doing in a day-to-day. Let us understand the importance of three things. One is calcium, phosphatase, and alkaline phosphatase. This is a table which gives you a fair idea as to how the parameters, if they change, we can think in terms of getting idea about the secondary osteoporosis. Using MRI for a three-dimensional grams per centimeter cube is still not in a way, it's in a nascent stage. We don't use that in day-to-day practice. We don't even use bone scan and bone biopsy. So these are the few entire buffet of tests which are available. It is up to the orthopedic surgeons to use as per the patient, as per the economic condition, as per the availability of the investigative test. And the main aim should be that they find out whether the patient is normal or he is in the or she is in the early osteoporotic stage. Thank you.
Thank you, Dr. Jain, for your very great ABCD of understanding of the osteoporosis, investigations and the measurements and the markers. Thank you very much. Thank you very much. So, Professor Jha, any question
yes.
you have?
No, we will have question answer in the end. So
Yeah.
now we can invite Dr. Lalit.
Where is Lalit? Is he here?
Yes, yes, he must be there.
Here,
Dr. Lalit will be talking about only the spinal osteoporosis medical management, right? Not the surgical aspect.
Yes, sir.
Right, please go ahead.
Thank you, Professor Manish, Dr. Usha, Dr. Jha, Dr. Sunil, Marwah, Dr. Prakash, all the speakers. All of them covered most of the part. So I will try to conclude as
short as possible.
Fast, yeah, sharp and fast. Is my screen visible to all?
Yes, yes.
Yes,
Visible,
yes.
audible.
Okay. So, good afternoon, all. Is it running? Yeah.
Yes.
I think. Yeah, it's a condition which is characterized by low density.
Go into the details, not into the basics. Right.
Right, sir. So WHO classifications has been already described. So there are the two classifications. Other one is the primary and secondary. Then why spinal osteoporosis is important? Because this is associated with the osteoporotic compression fractures, which includes vertebra, which most of the time thoracolumbar region, and they are the silent fractures. They are unrecognized, occurs with trivial trauma, and second most common fractures after the hip fractures. In the some regions, the spinal osteoporotic fractures are the most commonest one. So why they are serious? They are serious because they are associated with severe debilitating pain, height loss, deformity, sometimes neurological deficit as well. So patient present with the back pain without trauma or trivial trauma, and sometimes present with a deformity. So their severity can be assessed by their of twofold consequences. They are associated with the high mortality rate and morbidity compared to the hip fracture of the same group of the patient.
Manish, I'm sorry to interrupt.
Ji, sir.
Can we come to the medical management straight away?
Right, sir.
Thank you.
So, okay, sir. So another aspect is the there is a predict for the future fractures, and which risk is 3 to 5 times of the vertebral fractures. So predictors of the vertebral fractures is the simple strategy to report the vertebral fracture to monitor the patient height. Height loss more than 6 centimeter from the previously measured, or height loss over more than 1 to 2 centimeters over 1 to 3 years is highly predictive. So differential diagnosis to be differentiated, investigations already included. For the simplicity point of view, German Society Orthopedic Associations has included, there is a classification which says stable fractures 1, 2, and 3 should be managed conservatively with the medical treatment. And goal should be of the, because we have to talk about the management of the osteoporotic fractures which are managed with the conservatively medical treatment only. So goal should be the pain management and minimizing the function, maximizing the functional outcome. So indications are the type 1 to 3 type of the fractures, stable 1 fractures, and medicines are to be given acetaminophen, paracetamol, muscle relaxant, narcotics. If NSAIDs are not controlling the pain, we can add narcotics as well, and they should be given in the multiple doses based on the titration of the pain control, because these old age patients have a their GI issues. They have issues with the absorption of the medications, clearance of the medications due to multiple comorbidities like liver or the kidney disease. Calcitonin can be used within 4 weeks and just to control the pain only. So conservative treatment also includes various type of the orthotics which should be used for the 12 weeks, and they are associated some complications which are manageable most of the time. Early sitting, standing, and walking once pain control is adequate. So a non-pharmacological treatment is already been considered, like adequate calcium, vitamin D, weight-bearing exercises, smoking, limitations of alcohol, and fall prevention techniques. So calcium dosage should be given 1000 to 1200 milligram daily. And there are some literature that their calcium intake is associated with the kidney stones. So there are the two things. One is the calcium supplement, another is the dietary calcium. Dietary calcium is not associated with the kidney stones, whereas supplement may be involved. So we have to encourage for the dietary supplementation with the dietary calcium along with the supplementation. So there has been some reports of the cardiovascular risk, but this has not been found in the studies. They are the and there is another component of the management, vitamin D treatment, which is to be given 600 to 800 international unit daily. So there are the different recommendations for the pharmacological treatment. And treatment goal of the treatment is to reduce the risk fracture. Medications are categorized: anti-resorptives, bisphosphonates, estrogen agonist, antagonist, calcitonin, denosumab, and anabolic is teriparatide. So when we have to consider for the treatment, so patient with osteopenia or low bone mass with the history of fragility fracture of the hip or the spine. Number 2 T-score is less than -2.5, and despite the absence of the fracture, and patients with the T-score -1 to -2.5, if the frax 10 years probability for major osteoporotic fracture is more than 20%, or for the hip fracture is the greater than 3%. So there are the different drugs which has been recommended or approved for the treatment of postmenopausal osteoporosis, prevention of the postmenopausal osteoporosis, and treatment in the men also. So I am not going in detail in this. So first line of drug is the bisphosphonates, and for the treatment of the osteoporosis, this is postmenopausal women, men, and the glucocorticoid induced osteoporosis. These are the alendronase, risedronate, zoledronic acid IV. So they have been increased their BMD and the decreased risk of the fracture. Abandronate is not the first line of recommendation, even though high quality evidence indicate that it reduces the vertebral fracture. So it can be used in both men and women for the prevention of the vertebral fractures. But there is no benefit has been observed in the non-vertebral fractures. So dose recommendations are the 5 milligram for alendronate daily or 35 milligram weekly. Treatment doses is 10 milligram per oral daily. Same, it can be considered for the risedronate, 30 milligram once in a week, 150 milligram once in a monthly. Zoledronic acid 5 milligram every 2 years, 5 milligram every once in a year in the treatment dose. We have to consider for the creatinine clearance in this regard. for the starting the treatment for alendronates. Denosumab is the first line of therapy for the patient at the high risk of the fracture for the patient who are unable to use oral therapy. Denosumab was the first biological agent. It is injectable and dose is 60 milligrams subcutaneously at 6 monthly. And adverse effect has been dermatological reaction, musculoskeletal pain, hypercholesterolemia, and it can cause hypocalcemia. So supplementation with the calcium and vitamin D is must. Rarely there is a osteonecrosis jaw has been associated. Dose adjustment are not recommended for denosumab in patients with the renal and hepatic impairment. Drug holiday is not recommended in denosumab because after treatment cessation there is a decrease in the BMD even after 2 years of the treatment. There are the other therapies like estrogen agonist therapies, which includes raloxifene. They have dual agonistic and antagonistic properties in the estrogenic pathway, act as a estrogenic agonist on the bone by decreasing the bone resorption and bone turnover, thus increasing the BMD. It has also estrogenic activity on the breast and uterine tissue. So an appropriate first line of therapy for the patient requiring reduced risk of the spine fractures only. Raloxifene is in for the to reduce the risk of the spine fractures. So it can be used during the bisphosphonate holiday. Dose is 60 milligram per day without regard of the food. They have some associated comorbid complications also. There are the another thing which is conjugated estrogen and bazidoxafen, and it is has the same like raloxifene utilization, and it is used for the prevention of osteoporosis and the treatment of moderate to severe vasomotor symptoms patients with osteoporosis. Tablets contains 0.5 milligram conjugate estrogen and 20 milligram bazidoxafen once in a day. So due to the lack of the fracture data, actual efficacy of DV of PMO is unclear. Estrogen progesterone therapy solely for the prevention of osteoporosis in the high risk post-menopausal women and should be used only after non-estrogenic osteoporotic treatment have been considered inappropriate, because they have higher they are the risk and their benefit should be way compared to the treatment. Testosterone therapy have a limited studies used for the anti-fracture treatment with testosterone therapy for the man at high risk of the fracture. Testosterone monotherapy is recommended either for those in whom anti-osteoporotic therapy is contraindicated or whose treatment level testosterone level is less than 200 nanogram per deciliter, or those at the borderline high risk for the fracture whom have serum testosterone level more less than 200 nanogram per deciliter.
So,
Calcitonin, yes, sir.
So do you conclude?
Yes, sir. So calcitonin is main. If no drug is feasible, calcitonin can be considered. Strontium relenate is the another one which can substitute for the calcium. Not approved by FDA, but EU is using this one 2 gram per day. So another is the teriparatide and abaloparatide, which already been considered by the other speakers. So so there are the other drugs which are in the future. There is a romosozumab, odinacatinib, and lesofexanib. Thank you.
Thank you.
Thank you very much, all the speakers,
Achha,
including
yeah.
Dr. Lalit.
Lalit.
Yeah, you stop sharing, friends.
Yeah, Lalit has, yeah.
There is a great message from the presentation by Dr. Mohit. And to this, Dr. Marwah also says yes, that it is, if it is recommended, I'm talking of anti-resorptives. So if they are recommended for pediatric patients, they are really recommended for pediatric. And what I have to add is, what is safe? Many drugs that we use in adults are not indicated either in children or during pregnancy. So here, during pregnancy also, you have seen that one of the anti-resorptive can be safely used, that is risedronate. So a drug which can be safely given in pediatric conditions can definitely be used in normal healthy adults with osteoporosis on.
Yeah. Mohit has-
So whenever we conclude, we can never say that these drugs are not to be used. We will say they are to be used. Oral and intravenous use will depend upon various conditions enumerated by the various speakers. Now, talking generally about osteoporosis, what I would like to say that we always discuss osteoporosis and forget to talk about sarcopenia, and also a related term which is known as dynapenia. So dynapenia is that you are not as dynamic as you were, and ultimately sarcopenia and dynapenia lead to frailty of the person concerned. So the treatment of osteoporosis should always be accompanied with management of sarcopenia. So this is one thing important. Investigations have truly been considered in the right spirit, including everything. I would like to add that since we have to make a differential diagnosis, an investigation of beta-2 microglobulin. Beta-2 microglobulin must be done in patients where you have investigated and found out that multiple myeloma is not the disease. It still could be raised. The level of beta-2 microglobulin, if it is raised, it is monoclonal gammopathy of undetermined significance, MGUS. So this one investigation is also recommended. Simultaneously, if at all any surgery is contemplated, especially from the spine, a biopsy can be taken, because there are statistics that 2 to 3% of patients with all investigation, no malignancy has been ruled out, and still 2 to 3% of patients can be malignant on biopsy. Now, I hand over the topic of this second part to Dr. Chinmay Das. Professor Chinmay Das, you are there? Professor Chinmay?
Yeah,
yes, sir. Yes, sir. I am there.
And now, please take over and have your concluding remarks.
Meanwhile, I just want to ask a question to
Yes.
Professor Tiwari. Just as been discussed, and just general consensus has been taken that Resendronate is for a pediatric fractures, pediatric patients. Similarly, what is your take-home message for the renal osteoporosis patient? Which is the best drug, in a nutshell, which we can rely upon at most of the time?
What a bisphosphonate we can use if GFR is more than 30 ml per minute. So bisphosphonate, part of the calcium vitamin D bisphosphonate you can use, sir. Only thing that denosumab, you can use any GFR. And Oloxifene, any GFR, you can use that. But bisphosphonate is GFR stage 3 and beyond, you can use that. But if you're using for the quite long time, there is accumulation of the drug in the bone, and that leads to the fracture. So should not use more than 3 years. So, but GFR is more than 30, you can use.
Perfect. So again, here the bisphosphonate comes to on the line. Thank you so much.
Right.
Yeah.
Over to
Dr. Chinmay Das.
Sir, just to add one more thing, sir, Dr. Tiwari, sir, do you differentiate between adynamic bone disease or a dynamic bone disease in case of CKD?
You have to. Otherwise, that's why you have to do the PTH level. If your PTH is high, there is the problem. If adynamic bone disease, you have to see the calcium level and PTH level. PTH is low. There is no secondary hyperparathyroidism. This is adynamic bone disease. Always you have to.
But Mohit has done a very intelligent addition, Mohit, for pediatric osteoporosis.
Yes, sir.
Mohit has done a very intelligent addition of making these boys dynamic, because nowadays they are reluctant to go to the field. So he has actually let the cat out of the bag. That is advising the students to go for the activities.
Let the discussion continue. Dr. Chinmay, are you there?
Yes, sir.
Please
sir,
take
I'm
over.
very much
Please
here.
take over. You're right.
Sir, we had a very good session and a very,
Yes, go ahead. Go ahead.
yeah, very lengthy one also, sir.
Right.
So almost it is 2.5 hours. And I am very much thankful to our
Is there any extra
IOA
sound?
president.
Sir,
Extra
I am
sound
also
coming.
there, sir.
Dr. Lahkar, please.
Yes, sir. I am also very much here.
No,
And
you
then,
make it.
Yes, sir.
Make it mute because the extra sound is coming.
Extra, yeah. He is in a car. Yeah.
Right.
Yes.
Dr. Chinmay is saying, yes.
Yes. So I am thankful to the speakers, especially our on spine osteoporosis of the spine, then osteoporosis in pediatric osteoporosis. Actually, this is a new term for me because I thought that osteoporosis is always related to your adults. That word is referred to for adults, but today I came to know that it is referring to children's also. So in children's, actually, what I was taught that osteoporosis is not the term. Rather, we go for osteogenesis imperfecta and all those terms in pediatrics. But so this new thing I learned today regarding the pediatric osteoporosis, and definitely this is learned by the learned group also, as well as our audience, which we could not see because this is live telecast in your Ortho TV and IOA TV. And thankful to all the speakers, sir, especially Jha sir, who is the main coordinator, and he is the person behind everything in this discussion today.
Yeah.
And Dr. Subir Mukherjee sir, Shanendu Samando, then Ravi Sahuta, then S.S. Amarnath from Bengaluru, Sarika Srivastava from Agra, Abhay Elhans from Jodhpur, and Gururaj Sangodimat from Delhi, as well as Alok Agarwal ji. Alok sir has left, I think, but Alok Agarwal from
well, Dr. Chinmay,
Yes.
I will just interfere. Dr. Gurunath has to make some comment. Dr. Gurunath on spinal osteoporosis, medical management.
And lastly, Tiwari.
Gurunath, are you there? Gurunath?
No, sir, he is not there.
He is left. Okay,
He
fine.
left.
Yes,
Then
yes.
it is okay.
Yes, sir, I'm there.
Oh, he must be there. Yes. Gurunath.
Yes, I'm there.
Guru, yeah, Gururaj. Gururaj, sir.
Sorry.
Actually, sir, after so much of discussion on medical management,
Right.
Basically, there is not much of a difference between managing a spinal osteoporosis medically. But the only thing is, whenever we have fractures, the medical management differs a bit. Maybe like for spinal osteoporosis, we all seen that denosumab and teriparatide, these are the two wonderful drugs. I think there is no other drug which really acts as wonderfully as these two drugs. But then oral bisphosphonates, again, as the discussion was going on, I have also not used since last 5-6 years. No oral bisphosphonates I have used. Zoledronic acid occasionally. Once the denosumab has come, the usage of zoledronic acid also has gone down, and it is mainly teriparatide as the denosumab. So I think that's all. Otherwise, I think most of the things have been.
Just one intervention. What is the youngest stage of your patient in which you have used denosumab?
Yes, sir. Basically, because denosumab we all know that it's more safer because teriparatide has a life to use it. And with our treatment with the secondaries and malignancies in children, we have seen that it is safer. So the youngest stage where I've used denosumab is 35 years.
5 years.
35 years.
Okay. Yes. Chinmay, continue.
In continuation, and what Dr. Chinmay was saying is that pediatric osteoporosis is, of course, a now unknown entity, but frankly speaking, in our practice, we got to differentiate between osteomalacia and osteoporosis.
Yes.
And over the years, people have forgotten osteomalacia, and that is an important aspect. In my clinical practice, I feel most of these pediatric patients who come with pain, with a loser zone, with pain in the hip or the pelvic region, they're osteomalacic, not osteoporotic. So that is also a point that I would like to point forward.
So I think, sir, I just want to add.
I agree. I agree
just want to
totally
add
with
to
Dr. Srivastava.
I just want to add to it, in pediatrics, if there is no secondary cause, I think we have to suspect first osteomalacia rather than osteoporosis.
That's it.
Right.
Right.
Dr. Usha, if she has to make the last comment
Sir,
about the
sir, may I ask something?
Yes, please.
Sir, do any of the panelists, they advocate strontium renalate? Yeah.
We are not using it.
No, no. So that is out actually. But
out of the
yes, Swarnendu, you wanted to say something.
The strontium is already out of the box. It is not been recommended. I think it's now. It is absolutely out.
But one of the recently I attended one osteoporotic CME in medicine with the physicians, medicine people. They advocated the strontium renalate. So yeah, and the physician people. So whether it's confirmed that it is out or
no, I think it is most of the physicians in. I think
it is mostly out, sir, because still American College of Endocrinology are again not recommending it at all.
Even in the recent guideline by the endocrine people, and it is all over the world that it is not been listed.
Not recommended.
Dr. Usha has already left.
Usha has already left.
Okay, fine.
And we must thank our
Chinmay bol rahe the. Chinmay ko bolen.
Chinmay kahan gaya?
Sir, lastly, I just have to thank you all, sir. I don't have any comments. And today I have seen Atulji since starting. He is sitting here with us.
I am all yours, Chinmay, always.
So
I'm actually
so
now
very good representative.
We go non-academic, and Amarnath sir and Dilip Muzumder sir, the world knows what he means to me. Jha sir, the world knows what he means to me. So it has been, Sir Jha sir, a fantastic discussion to begin with, and we shall take it forward. Okay. We are for a larger platform. We are working for a larger platform, and thank you all. Jha sir is there, and I really appreciate Dr. Shantanu.
Yes.
Every one of you.
So the word thanks has been used. So it is the honor of Dr. Tiwari, K.D. Tiwari.
The vote of thanks.
Vote of thanks.
Right. आपकी बारी आ गई.
Dr. Tiwari is there.
I would like to thank everybody for such a long session on osteoporosis primary and secondary, and we have the power-packed speakers, number of speakers today. So I would like to thank Dr. Ramesh Sen, Dr. Ramesh Sen and our Dr. Thakkar, our leader, and Dr. S.S. Jha.
Yes, please.
Are you able to listen?
Yes, we are hearing.
I would like to thank our leader, Dr. Ramesh Sen and Dr. Navin Thakkar, leading right from the front, and Dr. Jha, always there in the middle to help you to propel the thing and to give the decisive remark and so many things when he is always there to rescue and to keep the ball rolling. Dr. Bhushan, always our opening batsman. Today he started, but he gave some important tips. Manish Khanna, our reliable and most reliable person, always available and having a useful tip for everything. And our legend, Dr. Professor Sunil Marwah, right from our armatorium, Dr. Jha has introduced him. among us. He has provided his guidance, and thanks to Dr. Jha for bringing Dr. Marwah among us. And Dr. Atul Srivastava, the captain in waiting, would be leading from the front next year in full pro. Next, our leader, Dilip Muzumder, president of our Rheumatology Society, always there to help you. Dr. Amarnath, guiding with Dr. Usha, Sriram, and Dr. Agarwal. He was giving some important tips. Now, I'd like to thank for the secondary osteoporosis speaker, Mohit Arora, the new lad, pediatric osteoporosis. He is doing good job, and legend in that field, Dr. J.P. Tiwari, nephrology, given a lot of information regarding the dealing with the other causes. Dr. Jha is always there. He talk about the glucocorticoid, and Dr. Jain, very important, the preventive aspect. He covered right from the Gujarat, from the heavy rains he was here. And Dr. Lalit, our backbone, the spine surgeon, he took the part. He had little less of the time, but he did the well. And Dr. Chinmay Das, very smartly covered right from moving from here to there. That's the message from the osteoporosis. Keep on moving, like our Chinmay Das, and you won't face so many problems. And Dr. Jain has given a lot of tips how to avoid osteoporosis. Follow those rules. And my sincere thanks to everybody for listening and bearing such a long session, but very fruitful for everybody. Thank you, sir.
Thank you, Dr. Tiwari. Now, one thing more. Against the trend, after thanks, nobody speaks. No, Dr. Amarnath. Dr.
Amarnath will say few words
Amarnath.
because he has introduced Usha. Dr. Usha.
Dr. Amarnath.
Sir, good evening.
Oh, yes, please. So how can we leave without your uttering few comments? So,
No. You told me that I'm going to be an observer. I have been since observant.
Yes, you have been observer. Now you have to be interactor. So now you have your final comments. Nobody else will be responding to that. Please.
No, absolutely fine. I think all is going well. One, that is true. And then I think we need to definitely come on to the board of writing a very non-dogmatic protocol so that everybody understands it in a very clear, simple English. Two, and there is no confusion in what to be used. So I think all of us, all of you, all of them who have presented today have come out with the fantastic presentations, no doubt about it, and no questions on that at all. I think we will formulate all that and then we will coordinate and probably submit to the Delphi board.
Right. Okay. And Dr. Swarnendu, have you left? Swarnendu? I have checked my WhatsApp. He has sent me a recommendation of British Orthopaedic Society of 2017. I have briefly gone through it. Not only 2017, I have recommendations from American Bone and Mineral Research Society, and they have recommendations of 2020, and all anti-resorptives are there. So, friends, with the word that anti-resorptives have not left us, and we are also not leaving the anti-resorptives. So, with these words, we leave today's meeting.
Together.
Right.
Thank you all. Thank you, guys.
Thank you, sir. Thank you so much.
Thank you, everybody.
Thank you, Chinmay. Thank you.
Thank you.
Thank you, DP, sir. Thank you so much.
Thank you.
Thank you, Professor Jha.
So, Amarnath. Amarnath, yeah. I am coming to Bangalore. St. John's.
Thank you, bye.
So, okay, sir.